بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. السلام عليكم ورحمة الله وبركاته. Welcome everybody. Uh, uh, it's my pleasure to be with you today in the second day of our symposium or the course about diabetes, which is Diabetes Made Easy. Yesterday, the first day was about some of the fundamentals about the diabetes with my colleague, Dr. Hamid. And today I will try to complete the journey to talk about some further diabetes management and how to deal with this common chronic disease. Before I start, just to announce that our break will be, the first break will be about 4 p.m. Because of the different time zones for the audience to go for Asr prayer. So between 4 to 4:30 is the first break to allow all of us to go for the Asr prayer. With no further delay, I will start my presentation or first presentation today. My first topic today will be about insulin indications and barriers. We know that the insulin is a cornerstone in diabetes management. It is actually used definitely in all cases of type 1, and maybe in the beginning of type 2 you have to start in some patients, and we'll talk about these patients or those patients, and we'll see what are the barriers to use this medication. My pleasure, I like you to follow this Twitter account. This is a scientific account about endocrinology and diabetes. So if you are interested to know about update in the field of diabetes and endocrinology, you can follow the Twitter EndoDMOS. It's actually a pure scientific one about the knowledge of diabetes and endocrinology and updates from time to time. The American Association of Clinical Endocrinology, we know the guidelines shows us that from the beginning, if the patient with type 2 diabetes, sometimes you can start insulin from the start. What are the indications to start insulin from the start in type 2 diabetes mellitus according to the guidelines? You see here, if the A1C more than 9%, especially if the patient is symptomatic. What are the symptoms? For example, polyuria, polydipsia, decreased in the weight or catabolism catabolism symptoms. I mean, these are the indications to start insulin from the beginning. So A1C more than 9, in other guidelines more than 10 is indication to start insulin in type 2 from the start. So this is the up-to-date, tells us when to go for or to start insulin for type 2 diabetes mellitus. As I showed, or as I mentioned, if the patient has catabolism or patient has symptoms like polyuria, polydipsia, and weight loss, A1C more than 9%, this is the indication to start insulin in type 2 patient from the beginning. Insulin is indicated as initial treatment as well in all patients with type 1, definitely. But if the patient presented with emergency, diabetic emergency in type 2, like DKA or hyperosmolar from the beginning, definitely again, the insulin use is the preferred method to give the treatment. What are the indications of insulin in type 2? As we mentioned before, A, catabolism, like for example, patient has weight loss. Number 2, fasting blood glucose high, which is 250 milligram per deciliter and more. Number 3, random blood glucose 300 milligram per deciliter and more. Hemoglobin A1C more than 10%. This is another guideline from South Africa. And definitely if the patient presented with DKA or hyperosmolar status from the beginning. So these are the indications to give insulin in type 2 diabetes mellitus from the beginning. What are the good news about starting insulin? Insulin is one of the best way to treat diabetes and lower risk of getting complication. Insulin, as we know, is natural substance made in the body, but due to diabetes, it is insufficient or there is deficiency. Taking insulin does not mean you have failed or the patient or the physician failed to treat the patient, but again, we can say the natural history of diabetes, especially type 2, there is regression in beta cell function by the time. Once you are diagnosing type 2 diabetes mellitus, definitely there is about 50% loss in beta cell function in the diabetic or newly discovered patient. By this way, your patient will survive his remaining life by another 50%, which is available. So this is a natural history of diabetes to have insulin deficiency even in type 2 patient. Insulin, need to know before you start the insulin, you have to educate the patient about the proper places or proper sites to inject, how to inject, the correct way to use the insulin pen, name of insulin, type of the insulin, color of the pens, how much and when to take it. All these are very important points to deal with them before you start the insulin, because many patients, they are confused. So you have to keep in your mind that the proper management, including a best or good education for all of these patients. Insulin pen, in the past, there was only insulin syringe, but now we have the insulin pen. So each special pen has a different type of insulin, different color, different mode of action, etc. So each patient has his way or how to, you have to treat each patient by the different way, because patient A different from patient B, and B from different from C, etc. Pin needle come in different lengths and sizes, and you have to educate the patient, as I told you before you start the insulin. What are the benefits of insulin pens? Patient satisfaction better than the syringes, increased likelihood of taking insulin, greater probability, less reported pain, greater social acceptability, and superior accuracy. We have the pen. In the past, as I told you, only syringes. The pen make the life more easy, different types of pen, different types of the insulin available. So the availability of pen make our life more easy. If the patient used to go for shorter pin needle, it is a best choice because it is less painful, and it is should be injected in subcutaneous tissue. Again, skin thickness and needle size. You have to know about the insulin is injected into the fatty layer subcutaneously. The more you weigh, the thicker your skin. Older people have thinner skin than younger people. Anyone can use a short insulin needle. You don't have to pinch up when using short needles. These are the precautions before starting insulin. Some non-injectable medication, I think Dr. Hamaid already mentioned some of them, again used as a subcutaneous injection, including GLP-1 agonist with the same way of insulin. This is an interactive question. I want you to give your input down in the chat box, please. So if you have an Aspart insulin pen, which is Novorapid, the trade name, the question here, it can be kept in the room temperature for how long? If you take it out from the fridge, it can be kept down in the room temperature for about 7 days, or do you think it can be kept up to 14 days or 28 days or 56 days. So please put your input down in the chat box. I will give you a few seconds while you are thinking about this question. Then I will give you the answer. So please write it down. Let us see your answers. So we have 28 suggestions. 28 days or up to uh, 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 4 weeks, 14 days. So we have different ideas from you, 1 month, 28 days. So these are the answers available in the chat box. Let us see here. What are the guidelines tell us? This is for all insulin types. The novorapid can be kept in the room temperature, as you can see here, up to 28 days, which are 4 weeks. Levemir or Detemir up to 42 days, Tresiba 56 days, all the types of insulin, it is summarized here in this timetable. So if you are interested, you may take screenshot of this timetable, which clarify the different we can say duration in which you can keep your insulin pen in room temperature, definitely away from the hot seats or hot sides, away from the fridge. This is the video of our topic. I will give you this topic just to give a quick summary, then you can understand more the idea. So please listen to the video.
Now you have profiles we already discussed. Now how do you initiate? Coming to the after the profiles, looking at the profiles, we know the profiles, how the insulins are, which are the components, which can be used where. So how to initiate? What are the practical tips? You have to discuss with the patient about insulin initiation and answer their queries in prior visits. Given written information or possible audiovisual material or to debunk the myths of the insulin therapy, then always reassure them about support. So before you start, 2 or 3 visits before you can talk about insulin, give them the material, talk to them about insulin, try to debunk their myths so that you are prepared to start insulin therapy. In one go, the patient is not going to accept the insulin therapy, so you have to start preparing slowly. Always reassure about support and initiating insulin for tryout for limited time. So always say, okay, I'll give you for temporary phase, I'll give you for 10 days, I will give you for 2 weeks. Try it out. After that, we can stop. So we can use it as a temporary tool and see if your blood sugars are getting control or no. Okay, one shot you can give in the clinic, so you can show them, okay, see that I'm giving a shot, nothing is happening to me, it is less painful, needle is so small, like a hair thin needle, and the patients will not change the mind. Make insulin initiation a pleasurable experience by avoiding hypo. Now, this is very important. That my thing is the patient should not get hypoglycemia. So insulin, when you initiate, patient should feel yes, I'm getting something benefit out of it. I'm not getting hypoglycemia. My sugars are getting controlled, and I have no problem at all. My lifestyle is not getting distorted or disturbed. So let's accept the insulin. This is what feedback will come. So if you use a better insulins, you will get a better experience, and the patients will also be happy. Start low dose and slowly up titrate the insulin. Follow up frequent during this phase. So when you're titrating the insulin, you have to tell them to follow up 10 to 15 days every, so you can understand what's happening. So the frequent follow-up is required when you're titrating. Don't just leave the patient. If you're sure patient is not going to follow up, then tell them to titrate very slowly, like every week 2 units. But if you are sure that the patient is going to follow up, then you can titrate faster. So this is very, very important. Self-monitoring of blood sugar is very, very important. You have to parallel with insulin therapy. So if you know insulin, but you don't know how to match with the self-monitoring of blood sugar, then you insulin therapy, you know half the knowledge of insulin. You have to understand when to tell the patient which sugar to monitor. So looking at a long-acting insulin, you have to tell them to monitor fasting sugar. Fix the fasting first. So when you are looking at the long-acting insulin, always start that, but it is much easier to start and go ahead, take the insulin therapy. So this is how you should start. So that's why you can break the barriers, because once you make the experience pleasurable for the patient, the barriers are not going to be there. And they have a lot of barriers like personal failure. The people think that I have failed to control my diabetes, so that's why my doctor is starting insulin, and that's the reason they feel guilty about that. They have a fear of complications. What is going to happen? Sugar is going to low. There's be needle phobia. There's be pain. Then regional issue, there are taboos, and people insulin चालू करने से लोग मर जाते हैं. हमारे कल्चर में ऐसा है कि इंसुलिन नहीं देने का. Lot of things are there which in their mind, which we have to answer. The hypoglycemic issues are there. Those have to be sorted out by using better insulin. Delivery issues are there. Non-compliance of the patients are there. There are people will skip insulin shots sometimes. They will not take insulin for weeks together, and that these are the problems. Lifestyle issues, because they are working, they're busy, so they cannot take your shot in the afternoon when they're going for office. So you have to think something out of the box, and then you have to give it to them. Economics and inequality in delivery is very important, because people may not have the sources to procure insulin, or costlier. It may be becoming costlier for some patients. Physicians' barriers are that they have a clinical inertia. They do not uptitrate the therapy. They have some kind of a barrier block in the mind that if I start insulin, my patient, or if I talk about insulin, patients are going to run away. And that's the major barrier in clinicians' mind. Because they don't have a knowledge, they don't have a skill, then they probably are scared to start the insulin. And because health education is ongoing, updates are not available, then also there is a problem. So logistics are also a problem. So that's why, as I said, people know about insulin, but they don't know which sugar to monitor. So then it goes, if you're this is half knowledge. If you don't know what sugar to monitor and which sugar to control, so which sugar you will tell the patient to monitor, you will not get any benefit of this insulin initiation. So how do you address the barrier? Communicate with the patient. Communication is a tool. Personal failure, diabetes is a progressive disease. Insulin is the best agent, as it is oldest and most used, so don't worry about it. It's a progressive disease. It's not because of your failure. Needle phobia, you can just show them the small needle. Easy to use pens are there. You can demonstrate in the office. Fear of complications if they have, then you can tell that when you give insulin, you can control your complication. You can control your blood sugars. Their side effects are less, and insulin is a natural hormone. Fear of hypoglycemia can be countered by saying that hypoglycemia was much more with the earlier insulin. We have newer insulin, and hypoglycemia also with the oral agents like sulfonylurea. So there's much but less hypoglycemia than some of the oral agents. Complex and inconvenient also, because newer insulin can fit into the lifestyle so easily because of convenience of flexible injection time. You can inject in a flexible time of yours, and that's what has the insulin injection has become now with newer insulin, with same effect and no side effects are seen. Fear of weight gain, no much. There, the new insulins, you can see hardly any weight gain nowadays, maybe a kilo or 1.5. So not much weight gain with the newer insulin.
Okay. I think in this video, one of the important issue that was discussed, I think, is the self-monitoring blood glucose. Please, once you are starting insulin, you have to keep in your mind that you have to give the patient log to register the blood glucose. Once you start basal, definitely you have to follow the fasting blood glucose. And once you are following with the postprandial, I mean, you are giving prandial insulin, like for example, Aspart or Lispro, definitely you have to give a patient instruction to measure blood glucose postprandial. So this is the usual habit. You start the insulin initiation or in a special dose, but most of the patient need titration up. So this is the message. Once you start the patient on insulin, don't leave the patient on the same dose. You have to follow them. If you if there is option to follow with you or with diabetes educator, definitely this is the best option. Maybe after, for example, 2 weeks or 3 weeks, or even after 1 week, either to be remotely or virtual clinic, or it can be physical or in person. All these options are available to convey the message of following the blood glucose. Sometimes maybe a patient has hypoglycemia, so definitely you have to decrease the dose, especially if the patient with type 1 diabetes mellitus. These patients or those patients are sensitive to insulin, and they are more prone to have hypoglycemia. One of the differential diagnoses may be Somogy phenomena. If the patient has hyperglycemia in the morning preceded by hypoglycemia, maybe the best option here to go for checking blood glucose at 3 a.m. One of the differential or other differential diagnoses with hypoglycemia in type 1, you have to think about adrenal insufficiency, for example, or celiac disease. We know type 1 diabetes mellitus is an autoimmune disease. So you have to think about other autoimmune diseases which may be associated with hypoglycemia with the same pathophysiology, which is autoimmune destruction. So examples, as I told you, of autoimmune destruction may be associated with type 1, including celiac disease. Patient in this situation have a malabsorption. Patient may be presented with hypoglycemia, electrolytes like hypocalcemia, for example, anemia, for example. The choice or diagnostic choice in these cases are going for antibodies, checking what are these antibodies. Anti-tissue transcoluminase antibody can be detected. If it is positive, the next step definitely to go for endoscopy. The second issue is the adrenal insufficiency. As I told you, any adrenal insufficiency patient has, if they have Addison, they will have the autoimmune, we can say Addison disease, autoimmune adrenal destruction or insufficiency. In these patients, what we have again hypoglycemia. In this patient, you have to check cortisol level in the morning. If it is low, definitely maybe you have to think about confirmatory tests, like for example ACTH stimulation test. ACTH stimulation test available using 250 mcg. You will give ACTH 250 mcg, and then you will measure cortisol level after 30 and 60 minutes. If it is not stimulated above the requested level, I will not go for details. It means patient has the adrenal insufficiency. I think by this, at the end of the first presentation, just to remind the audience about our Twitter account. It's a pure endocrinology and diabetes Twitter account, scientific one. If you are interested, please follow us in EndoDM OS. It's about update in diabetes and endocrinology field. But by this, this is the end of my first topic. We'll go for break now. As I told you, due to different time zone here in the kingdom, we'll go for a break between 4 and we'll be back inshallah at 4:30. Hope to see you soon. Assalamu alaikum wa rahmatullah. Welcome again. As I told you in the previous session or the first session, the journey here today is to go for details of the diabetes management. And for that, as per schedule, next session is about the basal and premixed insulin and rapid-acting insulin. So let's go for this journey to know the different types of insulin available in the market, what is the duration of action, what are the differences between all of them. I will try to touch all these as much as I can to overcome or to summarize the insulin therapy available in the market. Just a reminder for the newcomers who just joined us, we have a Twitter account about diabetes and endocrinology. It's about the update in diabetes and endocrinology field. If you are interested, you can join us. It is Endo, DMOS, ENDO, DMOS. So if you are interested in this field, please follow us in this Twitter account. Let's go now for the talk. This is the different types of insulin available in the market. A is the long-acting insulin, or what we call it a basal insulin. It covers about 24 hours per day. We have different types, including, for example, glargine and detemir. Glargine, it covers about 24 hours. Detemir, it's a dose dependent. It may cover up to 18 or 20 hours, and if you have a more dose, maybe it covers up to 24 hours. So it's like a basal insulin. It covers your back or the patient back of insulin need, and then you give further insulin according to the need. B is the intermediate acting insulin, what we call it NPH. It covers about 12 hours. So definitely patient need 2 injections of this NPH to cover it, to cover the whole day. Patient need 12 hours coverage by the first injection of NPH, and then intermediate action or intermediate NPH should be given again to cover the next 12 hours. So by this situation, you will cover a basal coverage by 2 injections of intermediate acting insulin. C, the short-acting insulin. Short-acting insulin, or what we call it the regular insulin, it's the insulin which is given before meals. It covers only the meals, and the duration will disappear, or the action will disappear within 6 hours. Last one is the rapid-acting insulin. It is acting rapidly. That's why you can inject, or the patient can inject insulin immediately before the meal, like Lispro and Aspart or Abidra, and the duration usually within 4 hours will disappear. So this is the different types of insulin available in the market. Let's go further now. Goals and objective in our talk is to be familiar with goals of and purpose of insulin therapy, understand barriers to use of insulin, current concept in insulin therapy, basal bolus insulin definitely. The key points, you have to keep it in your mind that insulin is highly effective but can be preserved as being a challenge for both patient and providers. Basal bolus insulin regimen require more injection, but provide better insulin coverage and better glycemic control. Insulin regimen and insulin dosing must be adjusted for each individual patient. This is a very important message. Our patient-centered approach is your way to manage your patient. Please, as I told you in the previous lecture, each patient has his way to be dealt with. Patient A different from patient B, patient B different from C, etc. So patient-centered approach is the best to be used in dealing with these patients. What is the purpose of insulin therapy? The purpose of insulin therapy is to prevent and treat fasting and postprandial hyperglycemia, because we know that the pancreas is weak in diabetic patients. So there is a surge of hyperglycemia postprandial and also in the fasting state. You give basal insulin to control the fasting or preprandial glucose level, and to give rapid-acting insulin to cover the postprandial hyperglycemia. Permit appropriate utilization of glucose and other nutrition by peripheral tissue, suppress hepatic glucose production, especially in the fasting status, to overcome the hyperglycemia in the morning, prevent acute complication of uncontrolled diabetes, prevent long-term complication of chronic diabetes. This is the usual normal insulin profile. This is for normal people down, pancreas or normal physiological pancreas secretion. There is a background insulin 24 hours, but patient or the person, when he eats or she eats, there is a coverage for postprandial more secretion by the pancreas. This is the mimicking the basal bolus you are giving. You are giving basal insulin. Bolus is with each meal to overcome hyperglycemia with each meal, breakfast, lunch, and dinner. I think this is again one of the important issues. There's to emphasize there is barriers to use insulin, including fear of injection, preserved significant of need for insulin, or worries about insulin could worsen diabetes. Unfortunately, this is one of the social background about insulin, concern about hypoglycemia, complexity of regimen. Barriers to insulin, as I mentioned before, here some of the studies shows us the barriers in both type 1 and type 2. Let us see the causes available. Some of the causes according to the studies available here is avoid injection because of anxiety. This is about 14%, and about 42% troubled by idea of more injection. And this is unfortunately we are facing daily in the clinic. In the social media, many ideas are distributed, including more insulin injection. Today, one of the patients came to me. She's using 100 units of insulin. Her A1C is 7%. Fortunately, she is coming to me asking to reduce the dose. I told her, any hypoglycemia? She told me no hypoglycemia. She is emphasizing that this is one of the messages received by social media. If you have more dose, it will harm you. Unfortunately, false ideas distributed in the social media, and this is our role as a healthcare provider to give the patient proper message. Again, high anxiety about the injection, including avoid injection because of anxiety, and troubled by the idea of more injection is the what we are seeing, the causes or barriers to use of insulin. Let's go further now. Here, how do you help patients accept and prepare for insulin therapy? As a healthcare provider, this is your role. As for example, doctor or nurse or educator or pharmacist, all you have to keep in your mind that you have to give the proper advice to your patient. Help patient accepting and preparing the insulin therapy. You have to address patient concern. Let us discuss with the patient his concern or her concern. Dispel fear of countering the misconception. I gave you just an example of my patient. The second issue, review rationale for using insulin. Explain that the insulin can be incorporated into lifestyle using especially the insulin pen or insulin pump. And the pump, we have, inshallah, a special talk about the pump during our course. Causes only modest weight gain. Yes, there is weight gain, but benefit risk ratio is better to use because it has a better outcome. I mean, to use insulin, you have a better outcome in glucose control or A1C control. Is a common course of treatment for this progressive disease. I told you in the previous lecture, the natural history of type 2 diabetes is there is loss of beta cell in the pancreas. Once patient is diagnosed with type 2 diabetes, there is a loss of about 50% of beta cell. Patient will survive his remaining life by the remaining 50%. Definitely one day, and there is decline in the beta cell by the time. So one day he needs insulin from outside to overcome or to live with the deteriorated pancreas. Again, one of the issues here, promise a patient support and close follow-up. Monitoring can prevent hypoglycemia. As I told you, cornerstone is self-monitoring blood glucose, especially if you have facilities with diabetes educator. Technology can facilitate daily injection and reading. For example, we have a continuous glucose monitoring, including, for example, Freestyle Libre, which is changed by the patient every 2 weeks. It gives you a continuous blood glucose monitoring in the subcutaneous tissue with no break to the pin break to the finger of the patient. Again, so you have to utilize the available technologies available nowadays in our medical field or in the market. Here in this slide, we have different types of insulin, and we have the onset of action of each insulin type, peak, and duration. The first one is Lispro, what we call it Humalog. The onset is about 10 to 30 minutes. Peak is about half an hour. So immediately a patient can inject this insulin before he takes his meal or her meal. And the duration up to 4 hours, as I told you before, as a mean duration for this rapid-acting insulin. Number 2, Abidra or Grolozine. The onset is about 10 to 30 minutes because it is, again, one of the rapid-acting insulin. The peak is about 0.5 to 3 hours, and up to 4 hours is the duration of action. Number 3, again, rapid-acting insulin is Novorapid or Aspart. The same onset of action like the others in this group, and the same peak in this group, and the same duration. So as the pharmacokinetic and pharmacodynamic of the rapid-acting, almost pharmacodynamic and pharmacokinetic with the fast-acting insulin, almost the same in the clinical practice. Let's go now for the next one, which is regular insulin or rapid-acting insulin. Rapid-acting insulin, it takes about 30 to 60 minutes to work. That's why if the patient using these medication, you have he or she has to inject before meals in about 30 minutes before meal. Why? Because it has a delayed action. It needs 30 minutes to work. The peak is about 2 to 5 hours, and the duration up to 6 hours. Some studies up to 12 hours, but the usual is up to 6 hours duration of action of the regular insulin. MBH, I think I illustrated in the first slide. The onset is about 90 minutes. The peak is about 6 hours, and it covers 12 hours. Some studies shows it may cover 24 hours, but in the clinical practice, you need to cover the 24 hours by 2 injections. Last one is the Glaragine or Levemir. and this is well-known basal insulin. The first basal insulin is the glargine. Onset is about 45 minutes to work, and we have less peak with this medication, and it covers 24 hours. The insulin action, as I told you before, according to the insulin action available in the market. Just here, maybe I emphasize on some of the missed insulin, for example, Degludec or Detemir. This is again, it covers the whole day, 24 hours or 48 hours. It has less peak. And we have a glargine 300, again, less hypoglycemia, peakless, more than the previous available glargine and Detemir. So the new ultra short, the new ultra long acting insulin like Tresiba and Toujeo, better outcome because of less hypoglycemia. I think this duration of action of different types of insulin already illustrated before. See the difference in color. This is the coverage of basal insulin in orange, and we have the green one, which is the intermediate acting. The regular is the red line, and the blue one is the rapid acting insulin. What about the mechanism of action? As I told you, we have the exogenous administration of insulin, the side effect available with the insulin, including hypoglycemia and weight gain. And additional comment about insulin, most administered by subcutaneous injection or infusion, most effective treatment, but also feared and risky treatment for diabetes. So many insulin to choose, including regular insulin, MPH, basal insulin, rapid acting insulin, basal bolus regimen. It is called again in another word, MDI, multiple daily injection regimen. We have a basal insulin like MPH, and you give regular insulin to cover the means. So if you have this terminology, MDI, multiple daily injection, it is equal to basal bolus regimen. So giving MPH twice per day and regular insulin each meal is the proper management if you like to go for multiple daily injection. If the patient is not controlled, for example, on basal insulin alone, definitely you go further either to use pre-mixed insulin or to use multiple daily injection regimen. Patient with type 1, definitely from the beginning should be on basal bolus or MDI because of the insulin deficiency in this patient. Let's talk here about the pre-mixed insulin therapy. The pre-mixed insulin, from its name, there is a mixture between two types of insulin. Usually in the market, we have a mix of MPH and rapid-acting insulin. This is the usual available combination or mixes insulin available in the pens. Advantage, relatively easy because it is given once or 2 or 3 times a day, not 4 times like basal bolus regimen. The usual regimen here is 2 times per day. Another advantage is it covers insulin requirement through most of the day because, as I told you, we have 2 types of insulin in each injection. And the best the best advantage, it has less or fewer dosing 2 times per day if you compare it with the other types of like basal bolus 4 times per day. Disadvantage, greater likelihood of nocturnal hypoglycemia because there is a rapid acting insulin which is given at night, and MPH, it has a peak. So after 6 hours or 8 hours of receiving the injection, there is a risk while a patient is sleeping to have hypoglycemia because of the effect of the MPH. Greater chance of fasting hyperglycemia. Why? As I told you, you cannot adjust your each insulin alone. Maybe you need more doses of rapid acting insulin at night, so you will increase the evening dose of mixed insulin. Ultimately, there is increase in MPH component, which may cause hypoglycemia in the morning, and the opposite is correct. If the patient has hypoglycemia in the evening, you will decrease the dose of mixed insulin, and MPH component will be decreased, and the fasting hyperglycemia will occur. So this is the explanation of the last item. Little flexibility with meal, need for sit times due to peaks of insulin in the daily life. Limitation of human regular insulin. I think this is, I will go through it quickly because nowadays regular insulin is not used a lot or commonly because it has slow onset of action, require inconvenient administration about 30 minutes prior to meal, as I explained early. Risk of hypoglycemia if meal is further delayed. Patient is not eating immediately, the meal is delayed, so the risk of hypoglycemia is there. Mismatch with postprandial hyperglycemia peak. Long duration of activity, up to 12-hour duration. In some studies increased at higher dose, potential for late postprandial hypoglycemia, as I explained before. Basal bolus regimen, and what we call it MDI. The MDI, or multiple daily injection, is the best regimen in the clinical practice. Why? Because the basal insulin suppresses glucose production between meals and overnight, especially hepatic production of glucose. Then nearly constant level, 50% of daily need by the basal insulin, and the bolus one, or the rapid acting insulin or mealtime prandial insulin, what we are seeing limit hyperglycemia after meal, immediate rise and sharp peak at 1 hour, 10 to 20% of total daily insulin requirement at each meal. So this is why it is important to keep it in your mind that the best regimen here is to give basal bolus regimen. It covers both prandial and the fasting or status, or the morning status of the patient. Here, this graph, it shows us that the insulin and glucose pattern usually in the normal patient, or in normal subject, or in normal person, and in type 2 patient. Usually the glucose in the normal population, after meals, there is an increase, definitely above the normal, but in patient with if the patient using insulin, there is almost coverage for this hyperglycemia. That's why the blue line will go down after usage of insulin. It mimics the usual normal pattern of glucose in the normal subject. So that's why it is preferred to use insulin, especially in uncontrolled or highly uncontrolled type 2, to mimic this pattern of glucose control. What are the clinical features of rapid-acting insulin? Insulin profile more closely mimic normal physiology. convenient administration immediately prior to meals, faster onset of action, as I mentioned, limit postprandial hyperglycemia peak, short duration of activity, reduce less postprandial hypoglycemia, but more frequent late postprandial hyperglycemia. Need for basal insulin is mandatory because, as I told you, rapid-acting insulin, it has no coverage for the fasting status, so basal bolus regimen should be combined together. Rapid-acting insulin analog like Lispro and Aspar reduces hyperglycemia postprandial, as it is here illustrated in this graph. I think this one already mentioned, but here the multiple daily injection is different little bit because we are using here rapid-acting insulin, not regular insulin. So you can combine MBH with the rapid-acting insulin or regular insulin. Lispro, Aspart can be given 3 times per day pre each meal, plus coverage of the basal insulin. What are the limitations of human MBH? MBH, as we mentioned before, it is the intermediate acting insulin. The intermediate acting insulin here is the intermediate acting insulin. It covers only about 12 hours. So do not mimic basal insulin, variable absorption, less than 24 hours, more injection 2 times per day, more hypoglycemia risk because there is a peak in about 6 to 8 hours, and more weight gain if you compare it with other available basal insulin. Let's talk now about the ideal basal insulin. I think we talked a lot about rapid and regular insulin. Let's talk or focus now on the ideal basal insulin. The ideal basal insulin mimic a normal pancreatic basal insulin secretion, as mentioned before. Long-lasting effect around 24 hours, smooth, peakless profile, reproducible and predictable effect, reduce risk of nocturnal hypoglycemia, once daily administration for convenience. So I think this is one of the important keys. Basal insulin given once per day, covers 24 hours, different types available in the market, including, as I told you, ultra long acting, which covers maybe more than 24 hours sometimes. So the patient, if delayed to receive his injection, plus minus 3 hours. In case of Toujeo, for example, it works to cover the whole day. This is the profile of various basal insulin available in the market. MBH available, as I told you before, it is the yellow line, and we have Glargine, the purple one. It covers 24 hours. We have the, for example, the continuous pump, continuous daily subcutaneous insulin. It is available and it is given as a subcutaneous. And tomorrow, inshallah, we have, I think tomorrow, yes, in this timetable, we have a full talk about pump. Long-acting insulin, as I told you, it covers 24 hours. It is analog, cannot be diluted or mixed with other insulin or solution, administered once daily in combination therapy. It is given with other types of rapid acting, like rapid acting and regular insulin. Which is better in type 2, in type 1, sorry, Glargine or MBH? Definitely this graph shows us the best coverage with the red line, because red line, it covers 24 hours as a basal insulin while you are using glargine, but the MBH coverage only is about 12 hours with peak, which may push patient for risk of hypoglycemia. So the best here is to go for glargine in type 1. It is not wrong to use MBH, but the best to go for glargine better than MBH. And last year, 2021, there was anniversary for the discovery of insulin, 100 years. It was discovered in 1921. This is a quick poll question, which is not basal insulin. I want you to write down in the chat box your input before I go further. Is it glargine, detemir, digludec, or dulaglutide? Please type down the answer you think it is the correct one. I will give you a few seconds. So I have seen here some of your input, majority going with the correct answer, which is D, but some things that A and C is the correct answer. No, dulaglutide D is not basal insulin, but others, all of them are basal insulin, including glargine, detemir, and digludec. Basal insulin suppresses hepatic glucose production. When used in appropriate dose, will maintain normoglycemia in fasting state. Prandial premeal bolus insulin covers the extra requirement after food is absorbed. DM type 2 require insulin, often first as basal, as I mentioned before, but boluses may be added later on if needed. And this is already seen before. In this picture, just to remind, in this picture, just to show us the usual pandemic way of diabetes. Actually, it is not the COVID-19 pandemic only. This is one of the African countries in which the patients in front of the doctor office. So it is a global pandemic. I mean, diabetes is a global pandemic. And if you have no rule in the prevention and definitely in the treatment, it will increase more and more. I have again an interactive question here. When will be the onset of insulin glargine action after subcutaneous insulin? This is just a quick stimulation. Please put your input. Do you think it is after 15 minutes, 30 minutes, 2 hours, 4 hours? So when glargine start to work, I will give you a few seconds. Okay, let's see your answers. A, D, B, 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 A. Actually, the correct answer is B. C. This is the correct answer. It will work after or sorry for interruption. I will share it again. Technical issue. So we are back now. I hope that everything is okay. So back to the answer of the question, which is the proper time to have insulin action after subcutaneous injection of glargine. The onset of Lantus, as you can see here, it works onset of action about 2 hours, Detemir 2 hours, insulin glargine 2 hours, Degludec 2 hours, MBH 2 hours again, regular insulin it needs 30 minutes, and peak effect different from each one as you illustrated here. But the good with glargine and Degludec, it has no peak, and the duration of action differs from according to the type of insulin used. Let's go further now. The basal insulin analog, different alteration result in slower absorption and longer duration of action. Insulin glargine, it is identical to human insulin except for one of the amino acid substitution. I will not go for the pharmacokinetics, but it precipitates in subcutaneous tissue, forming hexamer, which delay absorption and prolonged duration of action. Glargine, it is the first one, as I told you, less nocturnal hypoglycemia. The U100, it covers 24 hours and once per day, but some patients have better coverage with BID. If the patient uses large doses or huge doses of glargine, maybe it can split into 2 doses, or it can be given BID. Glargine 300, this is the ultra long new version of glargine. It contains 300 units per ml instead of 100. It has a more flat action and more prolonged action, more than 24 hours. Maybe it covers 38 hours. A window gap plus minus 3 hours if the patient receives his injection after 3 hours or minus 3 hours from its usual time. There is a good coverage, low risk of hypoglycemia, less weight gain as well. The next basal, famous basal insulin I want to give hints is that about is Detemir. Again, I will not go for the pharmacokinetics, but higher doses are associated with longer duration of action. As I told you, compared with the glargine, it does have a peak, or we can say a remarkable peak, rarely lasts up to 24 hours in the clinical practice. It is necessary to achieve acceptable basal rate coverage in type 1, so you can use it 2 times per day. Next one, Degludec insulin. One of the Degludec insulin is the Degludec is one of the new ultra long acting insulin. Again, this is the amino acid construction of the insulin. It is a soluble multihexamer form at injection site, from which monomers slowly separate and are absorbed, confers long duration of action, more than 40 hours with OD dose, steady state in 30 to 5 days. In contrast to glargine and detemir, may be mixed with rapid acting, less symptomatic and nocturnal hypoglycemia. This is from American Diabetes, American Clinical Endocrinology Association. Let us focus on insulin column. There is high risk or moderate risk to have hypoglycemia while you are using insulin. The weight gain is one of the side effects available. Definitely, you can use it, I mean the insulin in renal patient, but again, there is risk of hypoglycemia. It is neutral while we are talking about GIT side effect. Again, it can be used in cardiac and bone disease patient with neutral effect. What about inhaled insulin? Just quick slide. Inhaled insulin, it was discovered as oral inhalation and approved by FDA in 2014. First was in 2006, withdrawn from the market. There was a poor sale. Oral inhaled insulin causes rapid rise in serum insulin faster than subcutaneous injection for regular insulin. This is a very important issue due to its insufficient absorption from the respiratory tract. It needs a higher doses to achieve a therapeutic response. So it is contraindicated in chronic lung disease. You have to go for pulmonary function test before you start the patient on this insulin type. This is again an interactive slide. What do you think this photo illustrates? It illustrated one of the parts in the human body. Is it A, pancreatic cells, or B, insulin receptors? Please put your input down in the chat box. I will give you a few seconds. So is it pancreatic cells or insulin receptors? So I see here that A, we have some of B, but actually it is, sorry. It is receptors for insulin receptors available in this magnified picture. Just a quick reminder about the celebration of 100 years anniversary of insulin. Actually, into 2021, there was a celebration, as I told you, before the discovery of insulin. Unfortunately, diabetes was a fatal condition. The only treatment available at the time were fasting and calorie restriction only, but nothing was really effective to maintain adequate blood glucose level and keep people with severe form of diabetes. Today, it is known, which now it is called type 1 diabetes. So this is a quick overview about the discovery of different types of insulin or medication in the diabetes field. 1921 was the discovery of insulin. And then, for example, in 1936, first extended action insulin was discovered, and 1946 MPH insulin offers patient better insulin coverage. In 2000, first basal insulin, which was the glargine. 2013, next generation of the basal insulin analog. And 2017, first FDA approved smart pen. 2019, ADA standard of care include time and range phenomena, and I think we'll talk about it tomorrow in the bump topic, and further inshallah we can see in the future. This is the discovery, or who discovered insulin was discovered by Sir Frederick and Frederick Banting and Charles Best at the University of Toronto in 1921. And this is the first patient who received the insulin discovered by Frederick Banting and Charles Best in 1921. On 11 January 1922, Leonard Thompson, who was the first patient, he was about 14-year-old boy living with diabetes, became the first person to receive his insulin injection. This is his photo after treatment with insulin. I think I have some videos to summarize my talk, so try to concentrate on these videos, please.
Insulin regimens. There are various regimens for insulin therapy to fit with patient treatment strategy and lifestyle. The short-acting regular insulin can be given 3 times daily, 15 to 30 minutes before each meal. The insulin doses are adjusted according to the amount of energy in each meal. This is followed by injection of intermediate NPH insulin given in the evening to control nocturnal hyperglycemia. In another more intensive insulin regimen, ultra-short or rapid-acting insulin such as Lispro insulin injections are administered 3 times daily immediately before each meal. This is boosted by 2 injections of intermediate NPH insulin to provide basal pachygram level of insulin. One of the most intensive regimens consists of administering 3 injections of rapid-acting insulin immediately before each meal. In addition, a large dose of long-acting insulin, such as Detamir or Glargine, is injected in the morning to mimic the basal insulin pachygram. Finally, a less intensive and more convenient regimen, also called standard therapy. In this regimen, a mixture of short-acting and intermediate insulin in percentage of 30% to 70% is administered twice daily, in the morning and in the evening.
Welcome back. In this video, we'll talk about the different types of insulin and their characteristics. The injectable insulin preparations can be used for all types of diabetes, like type 1, type 2, and gestational diabetes. It works exactly like any other insulin by stimulating the insulin receptor, which is a tyrosine kinase receptor, and this triggers effect in 3 organs: the liver, the muscle, and fat. Once insulin receptor is triggered, the liver will store more glucose as glycogen, and the muscles will make more protein and increase the reuptake of potassium, and fat tissue will store more triglycerides. As a common side effect, all insulin preparations can cause hypoglycemia, hypersensitivity reaction to the insulin or its components, and of course lipodystrophy, which is a destruction of the local fat tissue due to repeated injections. We classify insulin into 4 groups based on the duration of their action. Rapid insulin acts very quickly, and the effect also disappears very quickly. This includes Lispro, Aspart, and Glulisine. These are especially useful in controlling postprandial hyperglycemia. The patient takes the injection before or during the meal, and by the time they finish their meal, the hyperglycemia would reach its peak, and the insulin would start working. Next, we have short-acting insulin, which is the regular insulin. It starts working in about 30 minutes and reaches its peak in 2 to 4 hours, and it lasts as long as 8 hours. This is excellent in treating hyperglycemia and DKA. Next, we have intermediate insulin. This includes NPH. These preparations are normal insulin suspended in protamine and zinc. This significantly delays the absorption of insulin. So it starts working in about 2 hours and reaches the peak in 4 to 12 hours, and it lasts as long as 18 hours. So patients can control their diabetes by taking intermediate insulin twice a day. And finally, we have long-acting insulin. These preparations are designed in a way to bind to fatty tissue very strongly. They also bind to albumin. This gives them the characteristic of prolonged sustained release. Their effects doesn't have a specific starting point or a peak, but they can last as long as 24 hours. These include Detamir and Glargine. And here's a small quiz for you. What is the management of diabetic ketoacidosis? And here is the answer. Alright guys, that's all I have. Thank you so much for watching, and hopefully this helps.
Quick reminder for those who missed the first part, you can join our scientific Twitter account about endocrinology and diabetes. It is EndoDMOS. So please, if you are interested in diabetes and endocrine field, you can follow us in this to have an update about diabetes and endocrine field. So by this, I think I am done with this lecture. I hope it was interesting for all of you, and I think maybe it's the time now to have your comment down or query, or questions. I will give 5 minutes if you have any question before I go further for the next topic. So please, if you have any question, you can write it down. Maybe I'll give 5 minutes to answer them. We have here, I think, one of the question about diabetic retinopathy. Is there any improvement of its treatment regimen? Like Eylea and Lucent injection and control the DM level. I think this is one of the terminology you have to ask ophthalmologist, not endocrinologist. I'm endocrinologist. I can answer about the control diabetes level. Yes, control diabetes level, it has definitely a better outcome to end the retinopathy. But I don't know about the injections. You have to consult the expert like ophthalmologist who knows better than me. I have no idea. In case of glucose toxicity, for how long I can use insulin? Use insulin till patient has a better A1C control, till it goes down. I mean the hemoglobin A1C. If it is controlled, I mean the A1C is controlled. It means the patient has a better glucose toxicity is, we can say, improved. That's why it is this, maybe we can say the better outcome to take it you have the glucose toxicity level is done. So I will wait 2 minutes if you have any question. Okay, I think no further question. Maybe we can proceed. يعطيكم العافية. طيب. I think we can proceed now for the next presentation. Next presentation or topic, we will talk about diabetes emergency. The diabetes emergency, one of the important topics, especially in the hospitals and in the primary health care, if the patient presented with acute severe illness. So I will give, try my best to give quick hints about how to deal with the emergency of diabetes, including DKA and hyperosmolar. So this is the two common scenarios in which diabetes emergency is there. DKA, diabetes ketoacidosis, insulin deficiency, and dehydration is there. And the second one is hyperosmolar status, in which there is dehydration and create more osmotic shift. Usually blood glucose above 250 in this situation or two situation. What about part of diabetes care and management in this diabetes emergency? How are the acute complications dealt with in your practice? Nursing and staff role, identification of the incident, clinical treatment protocol, education of the patient and the staff. All these you have to keep it in your mind while you are dealing with diabetes emergency. Who are the risks to have diabetes complication or emergency? A patient who using insulin, who patient using polypharmacy, elderly patient, very young patient, substance abusers, cognitive deficiency, others. Factors that affect blood glucose balance, you have to ask in case of diabetes emergency, including, as I told you, polypharmacy, again, very young, substance abuse. You have to ask this in the history, because if the patient, for example, using new medication like steroid, definitely it will push the patient for more hyperglycemia, and maybe will go for diabetes emergency like DKA. So ask about all these points in the history. Let's go further about the symptoms of hypoglycemia, which is known to us, but it will increase in diabetes emergency, like what? Increased thirsty, hunger, increased urination, fatigue, vision changes, vague and malaise, acute hyperglycemia leading to crisis, low level of circulating insulin, high level of counter-regulatory hormone, resulting in DKA or hyperosmolar status. HHS, this is the abbreviation in the references or in the box. This is a quick interactive question. Patient may has normal blood glucose and still has DKA. Can be diagnosed? What do you think? Patient, for example, blood glucose has of 150, and patient may be diagnosed with DKA. In the blood gas, he has acidosis and bicarbonate is low. Is it true, this sentence, or low? What do you think? Let's see your input in the chat box, please. True. I think majority going with true. Yes, and the correct answer, yes, you are true. Can be diagnosed with DKA can be diagnosed in patient with normal blood glucose. What are the precipitating factors in hyperglycemia which may push the patient into emergency like DKA? Missing dose of insulin, if the patient missed his or her dose. Acute major illness like myocardial infarction will push patient to more stress condition. CVA, sepsis, pancreatitis. Drugs, just I will give you an example like steroid, higher doses of thiazide diuretic, sympathomimetic agent, atypical antipsychotic agents, sodium glucose transporter 2 inhibitors, because these medication, there is risk to develop DKA like empagliflozin, dapagliflozin, canagliflozin, psychological problem, cocaine abuse, all these factors, as I told you before, you have to ask before go further, and including if the patient using insulin pump, maybe there is misuse of the insulin pumps. What about diabetic ketoacidosis? DKA is an acute severe metabolic complication of diabetes. It is characterized by ketoacidosis, there is ketone bodies, and there is hyperglycemia. This is an interactive question. Is it more common to see DKA in A, type 1, B, type 2, C, GDM, gestational diabetes during pregnancy? I want your input, please. I think majority going with A, yes, great. Type 1, more common to have DKA, definitely. Let's now talk about the differences. We know DKA is more common in type 1 at hyperosmolar non-ketotic status or hyperosmolar hyperglycemic status, HHS, more common in type 2. What are the differences? In DKA onset in 24-hour or less, there is dehydration, tachycardia, hypotension, acetone breathing, Kussmaul breathing, mental status ranges from alert to stuporous. In type 2, we have dehydration, tachycardia, hypotension, focal neurological symptoms, mental status range from confusion to coma. Difference in lab between these two conditions. In DKA, we have plasma glucose more than 250, arterial pH less than 7.3, serum bicarbonate less than 18, ketonuria strongly positive, serum ketone positive, serum osmolality variable, anion gap more than 10. HHS, we have plasma glucose more than 600, arterial pH more than 7.3. There is no acidosis usually, or above 7.3 in general. Sodium bicarbonate acceptable above 15. Negative to small ketonuria. Serum ketone small. Serum osmolality more than 320. Anion gap less than 12. This is the up-to-date differentiation between different grades of DKA, mild, moderate, or severe DKA and hyperosmolar plasma glucose. As I told you, 600 and above in HHS, 250 and above in DKA. In mild DKA, we have glucose, pH between 7.25 to 7.3. But in moderate, we have 7 to 7.24, 24, yes. And in severe cases, we have a pH less than 7. And usually in HHS, it is more than 7.3. Bicarbonate, 18 and below to 15 in a mild, 10 to 15 in DKA moderate, and less than 10 in severe. And HHS, usually we have, as I told you, acceptable bicarbonate 15 or 18 level and above. Ketone bodies, definitely it is positive in all grades of DKA, but negligible or small in HHS. Serum ketones positive in DKA and small in HHS due to dehydration probably. Anion gap is high in DKA, but it is variable in HHS. Stuporous and coma may be seen in severe DKA, and it is seen also in HHS. I think this is the classification of DKA. Mild DKA sometimes maybe can be treated with insulin subcutaneous, but usually in moderate and severe IV insulin infusion is the best way. Let's go for the current guidelines about management of DKA and HHS. HHS require hospital admission for intensive hydration and glucose management. DKA, home intervention to prevent progression, hydration with non-caloric and caloric fluid, insulin correction dose, close monitoring of glucose and urine, hospitalization for ketones, moderate or disease progression. Replacement is fluid loss is number 1. Number 2, key point correction of hyperglycemia and metabolic acidosis. Number 3, replacement of electrolytes imbalance for detection and treatment of precipitating causes. Markers of severity management in ICU. Glasgow Coma Scale, if it is less than 12, pH severe, low, less than 7 or 7.1, bicarbonate less than 5, severe hypokalemia, hypotension, desaturation, decreased urine output. This is the indication to definitely patient need ICU. We know that every patient with DKA should be in ICU, but sometimes if the patient has mild DKA, maybe can be treated in the ward, but these are the indication to shift patient immediately to the ICU. Immediate management in any patient with DKA, you have to go for establishment of intact airway, breathing and circulation, cardiac monitoring, urinary catheter, consider central venous pressure, nasogastric tube if necessary, if there is any necessary. You have to monitor vital signs hourly, cardiac monitoring, urine output. Which insulin types is used in infusion during diabetes emergency? Please, I want your input. Which type of insulin used in insulin infusion? Do you think glargine or regular insulin or detemir? Please put your input in the chat box. Let us see your answers. Majority going with B. Great. Yes, regular insulin is the one used in insulin infusion. Thanks for your input. This is a quick protocol of ICU management of diabetic ketoacidosis. I think details, it's not the scope of this lecture, but I will give you a few hints. You have to give IV fluid, like for example, normal saline, and you have to monitor serum sodium definitely, see the vital signs, most important one is the blood pressure. This is a replacement of correction of dehydration. If the patient has severe hypovolemia or mild hypovolemia or cardiogenic shock, maybe you can add ionotropic support if needed. This is number one, so IV fluid. Maybe you can shift it to another type of IV fluid, not normal saline. You have normal saline if the patient has serum sodium is high, for example. Again, if the patient has hypoglycemia or blood glucose less than 250, you can replace the fluid by dextrose saline in some situation. Next is the potassium replacement. Potassium replacement, if the patient has serum potassium less than 3.3, don't initiate the insulin infusion. In this situation, you have to wait till potassium is corrected, then you start the insulin infusion, because insulin infusion will worsen the hypokalemia. Again, the KCl replacement in each IV fluid bottle is recommended. Maybe you can give 20 to 30 milliequivalent of KCl in each liter of IV fluid if the potassium level between 3.3 and 5.3, and stop the KCl if the serum potassium more than 5.3. Number 3 category is insulin, and definitely the best route is to give insulin infusion intravenous. As I told you before, in mild DKA, subcutaneous insulin can be given. Regular insulin is the best way or best type to be given in the insulin infusion. You have to monitor blood glucose hourly. Rate can be increased or decreased of the insulin, infusion, according to the blood glucose level till the patient is out of DKA. Bicarbonate sometimes is given in severe cases, including bicarbonate. Intravenous can be given if the serum bicarbonate less than 5, severe pH, low pH less than 7. Again, these are the indications in which you can give intravenous bicarbonate. I think this is again repetition of what we call in a patient with HHS, IV fluid should be given, insulin should be given intravenously, and serum potassium again should be given. There is a big similarity or a great similarity between these two entities, how to deal with the patient with emergency. How to know that the patient has resolved DKA. Plasma glucose decreased less than 200 or 250. Serum bicarbonate concentration increased above 18. Venous blood pH improved more than 7.3, decreased or closed anion gap less than 12. In this situation, it means the patient biochemically has a resolution of DKA plus clinical signs, like for example, start to eat normally, start to receive his oral intake. So these are the signs clinically in which you determine the patient has improved or resolution of DKA. This is, I think, the hemoglobin A1C relation with blood glucose. For example, if the patient hemoglobin A1C is 7, estimated blood glucose range is between 123 to 185, and the average blood glucose is 154. And if the patient, for example, A1C is 10%, the estimated blood glucose range between 193 to 282, and the estimated average blood glucose is 240. So these are the how to know the blood glucose from A1C, or the opposite. If you know the blood glucose range, you can estimate A1C. This time table summarizes the relation between the two. One of the important issues in your mind when to check blood glucose and A1C, upon awakening and before meals, you have to ask the patient to keep blood glucose goal between 80 and 130 milligram per deciliter. After meal, if you take a diabetes pill, it should be less than 180, or even if the patient using insulin. And this is your advice for any patient discharged after DKA or after admission. A1C less than 7, bedtime glucose between 90 and 150 milligram per deciliter. I will give you summary in this video, so please concentrate on them.
Hey guys, Nurse Mike here, and welcome to SimpleNursing.com. Now, before we get today's lecture started, please remember to access your free quiz and preview our cool, nifty new study guides, not here on YouTube. Click the link right up here at any time during this video. All right, guys, let's begin. So how do you tell the difference between DKA and HHNS? Well, DKA is more common in type 1 diabetes and HHNS for type 2. So think which letter comes first in the alphabet. Well, guys, D comes first, so it's type 1, and H comes second, so that's how you know it's type 2. Now, what is DKA? Well, guys, let the name help you. Diabetic ketoacidosis. There is no insulin produced since it's type 1, guys. We have none. The body killed its own pancreas, and as usual, no insulin means no sugar in the cell. Therefore, the body must burn fat for fuel, resulting in fat waste, and ketone bodies are produced. Kind of like how a diesel engine blows off a lot of exhaust, ketone bodies are very acidic wastes. So we have high acid in DKA, or diabetic ketoacidosis. Now type 2, we have few insulins barely working, so HHNS or just HHS, let the name help you. So hyperglycemic, we have the higher sugar. Hyperosmolar, we have very thick dehydrated blood. Guys, huge dehydration here. And non-ketonic, we have no ketones, and S is for syndrome. Now, since the body has barely enough insulin to put sugar into the cell, while the body burns sugar for fuel, so we don't get those ketone bodies. So guys, think type 2, you have a few insulins working, so no fat burn, no ketones, since the body's burning glucose. Now, typically, DKA has a faster onset, and consequently, it's easier to fix, since the patients are young with type 1 diabetes. And HHNS is a slower onset with older patients. So guys, it's harder to fix HHNS. Now for the causes. DKA, remember the 3 S's like high sugar. So sepsis, like infection, guys, always an NCLEX favorite. The #1 cause of DKA is infection. Second S is for stress like surgeries or even skipping insulin. Guys, kids in type 1 will get the flu or an infection and then boom, end up in DKA. Or they'll go to surgery without increasing their insulin dose and then bam, DKA. And similarly, on the other side, older patients in HHNS commonly caused by illness and infections. So what are the main differences in the signs and symptoms? Well, for DKA, this is super hard, right? Just remember the acronym DKA. So D for a dried body, guys, and high sugar, 250 to 500 from the lack of insulin. Guys, that's a huge key word, 250 to 500 with type 1 diabetics. Now, K is for ketones and Kussmaul respirations, or known as fruity breath. Key words here for the NCLEX, deep, rapid breathing that smells fruity. This is called Kussmaul respirations, so think ketone respirations. So we say, ketones, do you love me? Are you riding? The body is in metabolic acidosis, so the body tries to correct itself, or basically compensate, and get rid of all this acid. It does it by panting like a dog to breathe out all that carbon dioxide, which we call carbon diacid. So remember, we'll see Kussmaul respirations as deep, rapid breathing as the body tries to get rid of all this acid. And the memory trick here is carbon diacid. Now next, our A is for abdominal pain, which is a huge NCLEX tip. HHNS does not have abdominal pain, only DKA, typically on the NCLEX. And our last A is for acidosis, metabolic acidosis, guys. Huge NCLEX key number here. Write this down. pH 7.35 or less. Huge number on the NCLEX. It will always show up on SATA questions. Now switching over to type 2, the slower and more serious one since it's harder to fix. So HHNS, guys, remember the triple H's here. We have higher sugar loss with higher fluid loss, so sugar over 600 plus, and extreme dehydration. And our third H is for head change. Now the NCLEX term is neurological manifestations. Guys, write that down. We'll often see confusion with classic signs of HHNS. Guys, we don't get head change or neurological manifestations with DKA. Our next N is for no abdominal pain, guys. DKA, we have that abdominal pain, as well as no ketone. So this means no acid, no Kussmaul respirations, basically meaning no fruity breath and no deep, rapid breathing. Now that's probably the biggest difference than DKA. And lastly, S is for our slower onset with stable potassium, 3.5 to 5.0. So when you get an NCLEX question stating high sugars with neurological changes or neurostatus changes, guys, with no acid, definitely HHNS. And if you get a question about a diabetic kid with abdominal pain and that pH less than 7.35, guys, it's most definitely DKA. So guys, what are we gonna do about it? So for DKA treatments, simply remember the acronym DKA. D for dehydration. Guys, we treat the dry first. Keyword is 0.9% normal saline. Now, I got a lot of questions on this from our NCLEX review, so please write this down. Your first priority action for both DKA and HHS is fluids. And the correct answer is always normal saline. Now, K is to kill the sugar slowly, guys, to prevent that low sugar. So we do keyword here, hourly blood sugar checks. Write that down. We want a slow sugar drop. Sugar is really way high, kind of like a plane. So guys, we want to land that plane slowly, not too fast, since we don't want to crash our patients here. The main goal here is to prevent that low blood sugar, that hypoglycemia, that 70 or less. So a slow sugar landing is the goal. So basically, as sugar lowers, then the insulin lowers. We just titrate or adjust the insulin drip and lower them together. Typically, any sugar over 250, we give IV insulin. Now, key term here, regular insulin only. So remember, regular insulin is ready to go IV. And we start with the bolus first, basically meaning rapid infusion. Now caution, tests will try and trick you guys. Only regular insulin is put right in the vein. Not NPH, not Aspart, not Lispro. No one else here gets the VIP pass. Remember, only regular insulin is right in the vein or ready to go IV. Now, when sugars drop below 200, or when, keyword, write this down, ketones resolve. This means the body is now burning glucose for fuel and not fat anymore. So we switch the patient from IV insulin to sub-Q and then add some dextrose sugar to the IV bag, typically D5W. Now you're probably asking, why do we add sugar if the sugar is already high? Well guys, it's kind of like landing that plane. Sugar is our landing gear. We want a smooth and slow landing, preventing that low sugar crash of hypoglycemia. Now a common test question is always a question about a child in DKA who's too nauseous to eat or maybe vomiting. And the question always says, do you still give him insulin if he doesn't have food? So think about it here, guys. Well, yeah, you still give the kid insulin, guys. His sugar's really, really high. Big NCLEX tip, still give insulin on those sick days. Lastly, we add the potassium. Key word here, write this down. During IV insulin, not after. During, big NCLEX tip. And yes, even when potassium is normal between 3.5 and 5.0. Now you're probably asking yourself why. Well guys, remember, insulin puts sugar and potassium into the cell. So naturally both sugar and potassium drop together. So to prevent a potassium crash, we add potassium, sort of like how we add sugar. Now a little side note about potassium. Think potassium pumps the heart. So the 4 rules of potassium revolve around protecting the heart with potassium. Number 1, our first action is heart monitor placement. And secondly, guys, we never push potassium. This means sudden death. The heart will cramp up and not pump anymore. Third, we only do 10 to 20 mLs max per hour. Not 30 minutes, not even 45 minutes, guys, per hour, a full 60 minutes or more, usually around 4 hours. And lastly, we always put potassium on an IV pump. Never a solo drip, guys, it's too risky. And as always, slow the infusion pump if the arm starts burning, which is pretty common. Now to help you remember the ECG rhythms with high versus low potassium, our memory trick is very simple here. So just think high potassium, we have high pumps. So we get peak T waves and ST elevations for potassium over 5.0. And the exact opposite for low potassium below 3.5, just think low pumps. So we get flat T waves and ST depression, and even this weird little U wave. What the heck's a U wave? Shut up, you. Now for HHS treatments, guys, remember the acronym HS. We always treat the hydration first. Both DKA and HHS, hydration first. 0.9% normal saline. Huge NCLEX tip, guys. Now, we can always do hypotonic fluids, but that's not as common on the NCLEX. And then S for stabilize the sugar with insulin. Again, caution, guys, only regular insulin is ready to go IV. Big NCLEX tip right there again. And just like DKA, we correct the sugars slowly with key term hourly blood sugar checks and insulin going from IV bolus to subcutaneous injections. We land that sugar slow. Now, as far as potassium for HHS, out of 10,000 questions we took while making the script, the potassium only came with DKA. So guys, remember, adding potassium for DKA. But a lot of questions came up about reassessing the hydration status. So write this down, guys. So we reassess both blood sugar and rehydration status. So for hydration, we'll see stable blood pressure, cap refill 3 seconds or less. And guys, skin, write this down, should not be pale or cold. It should be warm and have some color. Urine output should be 30 mLs per hour or more with normal specific gravity. Too high and the body is dry. So the little memory trick here is hemoconcentration is an indication of dehydration, basically meaning high and dry lab values, very heavy urine. And hemodilution is overhydration, low liquidy labs with low liquidy urine. Lastly, don't let the NCLEX trick you. Rehydration status does not include apical pulse, lung sounds, or even pupil assessment. All right, guys, that wraps it up. DKA versus HHS. Thanks so much for watching. For our full video and new quiz bank, click right up here to access your free trial. Hey guys, Nurse Mike.
I think it was, I hope that it was summary or good summary to summarize what we talked about. So please, if you have any query, you can share with us now in the chat box, any questions before we conclude this lecture. Just a reminder, we have EndoDMOS, a Twitter account, scientific one. If you are interested about diabetes and endocrinology, you can follow us in this Twitter account. Please, if you have any question, write it down in the chat box. I have here, thanks, interested video. Yes, thanks for your listening. I have a question here today. A 55-year-old male with diabetes on biogliflozin and combination metformin and empagliflozin, present 3 times in ER and primary health care with low blood glucose. The RBS is 44. I give glycogen, but after 45 minutes, I reach 500. What's correct approach to adjust medication? Little bit, it is confusing for me. The medication, maybe you mean bioglitazone. Patient is using metformin and empagliflozin. The patient presented with low blood glucose. I think Dr. Hamid yesterday, he gave you how to deal with the hypoglycemia. Definitely, if the patient is aware, you have to treat hypoglycemia orally by giving 15 grams of carbohydrate, like for example, dates, juice, etc. But you have to repeat blood glucose after 15 minutes. And after 15 minutes, if there is no improvement, give again 15 grams. Again, after 15 minutes, give check blood glucose. If it is not corrected, maybe it is the time now to give glucagon injection. If you mean, yes, glucagon injection can be given. But, and definitely a patient, maybe if it is corrected, to ask the patient to receive his meal, usual meal. If the patient not corrected, maybe to shift the patient to hospital. Definitely, patient using here bioglitazone, empagliflozin, and metformin. So what about renal condition? It is he has renal impairment, for example. The patient did not receive his meal today. How frequent he has hypoglycemia? All these issues you have to discuss before take decision which medication you have to take it out. Is using sulfonylurea, using insulin, for example. So all these aspects should be discussed with the patient. Sulfonylurea, insulin, more prone to cause hypoglycemia. If the patient not using these elements, maybe you can take one of the medication out. We know that empagliflozin, metformin, less to cause hypoglycemia. Maybe I will start with bioglitazone to take it out or decrease the dose, then go further if the patient still has hypoglycemia. Renal condition, as I told you, very important. General condition of the patient, if he has another disease. So all these are the issues you have to discuss with the patient before you take a decision to take the medication out. Any more questions in the chat box? Good. I have here a question here. What type and amount of fluid in cardiac and renal failure patient with DKA? Yes, this is a practical point. So the question here, we know that usually in diabetic ketoacidosis and in hyperosmolar anketotic status or hyperosmolar hyperglycemic status, you have to give fluid, and usual fluid, normal saline, 100, 150 normal saline, or in younger population, you can go up to 200 cc per hour of normal saline. The question here about if the patient has a cardiac problem or he has a renal impairment, if you give more fluid in this patient will go for overload and pulmonary edema may be there, and patient will go for definitely deterioration in his cardiac status, pulmonary edema, desaturation, and arrest. Yes, you have to go for less rate in this situation, definitely. Sometimes go for 70, sometimes go for 100, and definitely you need support from your colleague from other subspecialty like nephrology or cardiology. Inserting CV line, central venous line, is very important in this patient to know the central venous pressure and to guide you about the proper fluid rate to be given in this patient. Measuring urine output definitely again will guide you to select the proper rate in this population. Generally, again, to make it simple, decrease the rate of the IV fluid, take the opinion of your colleagues, insert central venous line, measures urine output. All these should be in the setting of ICU intensive care unit, because it is not easy, or it should not be treated in the usual ward because it is difficult situation or critical cases. I think I'm here. I hope that I answered your questions. I'm waiting your questions in the chat box or Q&A. Let me see Q&A. Yes. I think I answered this one. Yes. Okay. And in the chat box, I see no. Let me go up. I see no question in the chat box. Just to emphasize about the points mentioned here, in emergency situation, please, in primary healthcare situation, it is very important. Very important to deal with these situations because it is not easy to go for full lab. I know it is not available, like for example, blood gases. So if you have any query, if you have any doubt about diabetes ketoacidosis, especially as you heard in the video, patient presented with typical abdominal pain, nausea, vomiting, patient is type 1, missing his dose, high blood glucose, try to be safe, send the patient to emergency room to measure a blood glucose, to measure, blood, go for venous blood gases to see if there is acidosis. Sometimes in the primary health care, it is available to measure urine in the or ketone in the urine. It is very crucial that, you know, sometimes not all patients with positive ketones means has DKA. Dehydration alone may cause positive ketone in the urine. And the opposite, sometimes it is a patient with DKA has negative ketone in the urine, but he still or she still has diabetes ketoacidosis. So in this situation, please keep it in your mind that if you have any doubt, please send the patient to emergency room to take the proper management to investigate more. I asked you here one of the question about normal blood glucose with diabetes ketoacidosis. We have two conditions in which patient may be presented in ER with normal blood glucose and normal blood glucose and still venous blood gas shows acidosis. Pregnancy, one of them, and alcohol abuser, again, one of them. And if the patient, for example, received aspart or rapid acting insulin at home for correction or any primary healthcare center or dispensary before he comes to you. So again, with normal blood glucose may be presented still has DKA, as I told you. So don't rule it out from the beginning, go for further investigation. And the most important one is blood gases. Bicarbonate, pH will show low level, and definitely patient has DKA if the patient has metabolic acidosis. HHS, as I mentioned before, it is more common in type 2. Almost we can say the regimen or the treatment in both conditions are the same. I mean DKA and HHS. It is more common in type 2 in elderly population. The most important issue is to start fluid from the beginning, insulin infusion, potassium replacement, and with monitoring as we discussed before. I think I am done with my topic. I will see if, yes, one of the comment here from the audience, dapagliflozin or SGLT2 inhibitors generally may be associated with DKA. Yes, dapagliflozin, empagliflozin, because we know that the SGLT2 inhibitors may associated with dehydration, and it may prone the patient to more UTI because it takes the glucose down in the urine. Maybe these are the causes in which the empagliflozin or SGLT2 inhibitors in general associated with the DKA. In the practice, frankly, from my practice, at least in the last maybe 4 or 5 years, there is less incidence of hypoglycemia. There is no significant number of hyperglycemia with DKA while the patient using SGLT2 inhibitors. I think it's the time now for to end my lecture. It's the time for the break. You may go for coffee break and prayer because of the different time zones in the kingdom. We'll be back, inshallah, at 7 p.m. to complete our journey today in the second day of the diabetes made easy course. I hope it was interesting. I mean, yesterday and till now, it is still interesting for the audience, and I hope, inshallah, we can continue this interesting course to get benefit for all healthcare provider who are dealing with this chronic disease, diabetes mellitus. So we'll meet again, inshallah, at 7 p.m. to complete the other aspects or the other topics available in our agenda. Hope to see you soon. Enjoy your break. يعطيكم العافية. Thanks for your listening. Assalamu alaikum wa rahmatullah. Welcome again. I hope that the slides are clear and my voice it's clear. It's my pleasure to be with you today as we completed the first session today from our second day in Diabetes Made Easy course, and now we'll go for this second session for this topic, or the first topic in the second session will be about update in diabetes field. I hope my first session was interesting for all of you, and I hope that the coming few topics will be the same way. If you are interested to follow our in endocrine and diabetes field, please follow our Twitter account, EndoDM OS. This is a pure scientific account regarding diabetes and endocrinology. So if you are interested, please follow us in this Twitter account in front of you, ENDODM OS. With no further delay, I will go for the topic assigned to me. The topic here is about update in diabetes field. We know that the diabetes field is changing from time to time in a rapid way. So I will try to focus in some of the drugs and technologies available nowadays. So the field of diabetes care is rapidly changing as new research, technology, and treatment that can improve the health and well-being of people with diabetes continue to emerge. In this lecture, we'll try to focus on some of these updates. Some of the new medication available in the markets recently is the ertugrofloxacin. Ertugrofloxacin under the trade name of Stiglatro. It is under the group of SGLT2 inhibitors. I think my colleague Dr. Hamid yesterday, he gave you broad details about oral medication used in treatment of diabetes. This medication is approved in 2017, ertugrofloxacin. As in this group, we know it is used to treat type 2 diabetes mellitus. We have two concentration, 5 milligram and 15 milligram. It is given as once daily under the trade name of Stiglatro. The second medication is the Ozempic. I think this is again one of the new medication available in the market. Maybe 1 year back, started to be here after approval from the FDA. It is a semaglutide once weekly GLP-1 agonist. It was approved just 4 years back. Or 5 years back in 2017, and we have 0.5 milligram and 1 milligram injectable medication, and as GLP-1 agonist and all GLP-1 agonists, it is approved to be used in type 2 diabetic patients. We know that the Ozempic demonstrated superior body weight reduction. If you compare it with exenatide, which is a once weekly GLP-1 agonist as well, we have a better outcome in the term of weight reduction. Double, almost, the weight reduction reported with Ozempic if you compare it with exenatide. Semaglutide reduced major cardiovascular events by 26% also in adult with type 2 at high cardiovascular risk. That's why from the beginning, if the patient has a cardiac event, go for medication, or cardiovascular disease and he is diabetic, go for medication that reduces the cardiovascular events, including, for example, GLP-1 agonists with approved decreased events, and some of the GLT2 inhibitors according to the guidelines. One of the medication also approved recently in 2020 March in Europe, and in June United States of America, is Lispro AABC. This is again fast and short duration of exposure of the rapid-acting insulin. It is produced by adding one of the amino acids modified to the well-known rapid-acting insulin Lispro before, and of course, it is given before the meal to control the postprandial hyperglycemia as each and all types of rapid-acting insulin. Definitely, it is used in both type 1 and type 2, and we have two pens two concentration pens. We have 100 units per ml and 200 units per ml. What about insulin Lispro biosimilar? We have in the market, as we know, something called biosimilar. It is mimicking the original medication, but it is produced by another manufacturer or another way. That's why it is called biosimilar, and it is under the trade name of Admiloc. It was approved by FDA 2017, used in people or pediatric age group 3 years and older, type 1 diabetes, and adult with type 2, definitely. The product is approved for use as injection or during or through the pump or intravenously. It will be available also in vials and pens. What about this Gvoke? Gvoke is one of the medication which contain glucagon, and we know glucagon medication used to treat hypoglycemia. What is the difference between this Gvoke and the traditional glucagon pen? I will summarize it in a few slides, but I want you to know that it just approved in 2019, about 3 years back, by the United States FDA. It is, as I mentioned, glucagon injection, but it is, the difference here, it is ready to use. It is already mixed glucagon, no need for the usual mixing it with the fluid. This is the traditional glucagon available previously, but this one just to remove the cap and inject. So it is ready to use pen, room temperature stable liquid glucagon, and we have 2 doses. The pediatric patient can use 0.5 milligram, and the adolescent and adult can use 1 milligram. It is approved to be used in pediatric and adult patients with diabetes age more than 2 years. And it is the first glucagon product approved that can be administered via auto-injector Gvoke HypoPen or pre-filled syringe, reducing the steps to prepare and administer in severe hypoglycemia cases. Easier for patient or caregiver to administer quickly and simply. So it is a simple pen, just remove the cap and inject. This is more easy. Where are the sites in which you inject your pen? It can be given in usual sites, including lower abdomen, outer thigh, and outer upper arm. All these are the sites which is usually to use the subcutaneous injection. Here is the traditional glucagon pen. It needs, as you see here, maybe 7-8 steps before you inject. So in severe hypoglycemia and severe critical situation, you need something which is more fast. So it is more suitable to use a pre-filled pen, which is Gvoke. So glucagon kit, the old-fashioned, including saline-filled syringe and vial, which contained powdered solution. Many people may have been hesitant to use this difficult glucagon kits because it is complex. The preparation is including the following: removing the cap, remove needle protector from the syringe, insert the needle all the way into the vial, inject liquid from the syringe into the powder bottle, roll the bottle gently to dissolve powder. The solution will be clear. Draw the fluid, inject into outer mid-thigh of the patient. You see, 7-8 steps, takes time, more easy to use the pre-filled insulin glucagon to make it more easy. So a big difference, if you have this Gvoke, it will be more easy for you to be used in the critical situation. Again, in 2019, maybe 3 years back, the first oral GLP-1 agonist was approved by the FDA under the name of Rybelsus. The component or the generic name is semaglutide. It is the first GLP-1 agonist orally we know, again, it is used for type 2 diabetic patient, and it was called, or the game changer, because it is the first GLP-1 agonist orally. How to give and what is the effect? Dose of oral semaglutide 7 or 14 milligram, 1.5% A1C reduction with 3 to 4 kilogram loss is observed. Starting dose is usually 3 milligram, and it can be titrated up to 7 milligram after 30 days on the 3 milligram. And the maintenance dose again can be go up to 14 milligram if the glycemic control was not achieved. As I told you before, once daily, orally, the usual side effect of GLP-1 agonist, as Dr. Hamid told you yesterday, GIT upset like nausea, for example. And don't forget the usual precaution in any GLP-1 agonist, including history of pancreatitis, medullary endocrine neoplasia, medullary thyroid carcinoma. And one of the important issue here, it may worsen retinopathy, so it is recommended to go for follow-up for retinal examination. What about the use? As I told you, it is taken wait 30 minutes before the first food, and it should be taken with plenty of water to allow a good absorption. The next medication is sotagliflozin. Sotagliflozin is blocking both SGLT2 and SGLT1 in the intestine, and in Europe it was approved to be given, and it reduces A1C up 0.25%. What about this precaution? We know, as I mentioned before, SGLT2 inhibitors may push the patient to develop DKA. So there is some recommendation if the patient is overweight with BMI more than 27, maybe you consider using some SGLT2 inhibitors, but you have to keep in your mind that it is precaution because maybe DKA is developed. That's why by American FDA it is not approved, but in European countries it was approved, citing safety concern about possibility of increased risk of DKA. Still, the FDA, American FDA, not approve it. Let's go further for the some technology. Some of the technologies here is what we call it automated interoperable automated insulin dosing control or controller. If the patient goes for OR, instead of using, for example, insulin infusion, you can use this device. It was approved in 2019 December, Tandem Diabetes Care Control company. It is interoperable. It contains glucose monitoring and pump as well. Let's go now for the continuous blood glucose monitoring technology, which was seen recently in the market. I think more familiar to us is the one in the middle, Freestyle Libre, which was approved in 2016. It gives you a continuous blood glucose because you see this small item, like a sensor. It is fixed and subcutaneously or interstitial to the arm of the patient, and you can use the receiver, the black device, to take the blood sugar reading. The new version of this device has a connection with the Bluetooth, so the mobile also can detect the reading. So this is make our life more easy to detect continuous blood glucose monitoring. This is number one. Number two, the Medtronic Inversion Pro European approval in 2019. Dexcom, it was approved in 2019 for 2 years and older. What are the differences here? As I told you, your wearing time usually for the Abbott Freestyle Libre is 2 weeks, but Medtronic 7 days and Dexcom is 10 days. Finger sensation calibration, finger stick calibration does not need it in all of them. Disposable, all of them. The accuracy, the most accurate one is the Dexcom, and least accurate one is the Abbott Freestyle Libre. And as I told you, there is a new version of it in which there is a Bluetooth connection to receive the blood sugar reading. What is new about liraglutide? Liraglutide is well-known GLP-1 agonist to be given for adults with type 2. The new here is the approval in June 2019 for pediatric age group between 10 to 17 years of age with type 2 diabetes. So GLP-1 agonists, liraglutide, can be given for this group of patients in type 2 because, only insulin and metformin was approved only for type 2 diabetes mellitus in this pediatric age group. Just a comment, the GLP-1, it is extracted from the lizard, and the first synthetic peptide was taken from saliva of it in 2005. One of the American Diabetes Association new score available that may help you in clinical practice, including machine learning to predict the risk of incident heart failure hospitalization among patients with diabetes. You can use this score. It is called WATCH-TM score for 5-year heart failure incidence. What is the component of this score? W for weight, body mass index, A for age, T for hypertension, systolic blood pressure and diastolic as well, C for creatinine value, H for HDL, D for diabetes, and also for duration of QRS, and finally M for MI or myocardial infarction. So what is the benefit to predict the heart failure? This is, as you can see here, from the score, you will give in each category a specific score, and then you calculate the total at the end. If the total more than 14 points, it is very high risk to develop heart failure. And if it is, for example, less than 7, very low to develop heart failure in the coming 5 years. So it is predictable in the clinical practice. Sometimes this is one of the updates by American Diabetes Association, how to use it in the clinical practice. Let's go further. What is other new medications? We have the inhalation of glucagon, 3 milligram use or 3 milligram concentration under the trade name of Baqsimi. It is glucagon inhalation approved in 2019, intranasal, one actuation into single nostril. If no response, again can be given after 15 minutes. It treats severe hypoglycemia in diabetic with 4 years and older. So again, glucagon available in the this concentration or this formula. I will mention some of the diabetes medication under development, still under researches, and soon, inshallah, we can see them in the clinical practice. In addition to these new medications and technologies, several drugs under the researches nowadays. I think Dr. Hamid, he gave you hints about once weekly insulin yesterday. It is long-acting basal insulin given once per week. The half-life is about 196 hours, once weekly by the company of Novo Nordisk. We hope that once weekly insulin can be given in the market soon, inshallah. I think by this, just a quick reminder for the newcomers, if you are interested in diabetes and endocrinology, please follow our Twitter account. It is a scientific pure account about endocrinology and diabetes, ENDODMOS. EndoDMOS. Actually, it is about update in diabetes and endocrinology field. So please, if you are interested, follow us in the Twitter account. I will try to review Q&A. If we have any query, I will try to answer it. Okay, it looks like nothing in the Q&As or in the chat box from the audience. If no further questions or no query, maybe يعطيكم العافية. We can go further for the next topic. Okay, I will share the new topic now. My next presentation is sick days management. This is again our Twitter account if you are interested, if you did not catch it. Sure. I hope that it is clear now. Yes. So my next presentation will be about the sick days management. One of the important rule in diabetes management is how to deal with diabetic patient during sick days. You have to give special instruction for the patients, a special instruction for the relative, for the family, if the patient, for example, is child. So all these considerations should be kept in your mind before patient goes out from your clinic, especially if the patient has newly discovered diabetes. So in sick days guidelines, acute illness, complication, diabetes management, because of its varying effect upon insulin requirement. Increased insulin requirement are due to increase in the counter-regulatory hormones released in response to stress. The hormones, including epinephrine and cortisol, raise peripheral insulin resistance. Therapy, increasing insulin requirement. Decreased insulin requirement are due to reduced oral intake of carbohydrate because of decreased appetite, nausea, or vomiting. So all these considerations should be kept in your mind, because these are the usual maneuvers available, or the usual, we can say, scenarios in the sick days. Maybe patient will not go for good oral intake. He will be going for hypoglycemia. If the patient, for example, has more counter-regulatory hormone, maybe push the patient for more insulin resistance and more hyperglycemia. So Sick days management guidelines. An acute illness, patient may develop hypoglycemia, as we just mentioned, hyperglycemia, or maybe more difficult situation like diabetes emergency, including diabetic ketoacidosis due to inadequate insulin supplementation, ketosis independent of hyperglycemia. So management, including the following on sick day management. What should you do? You have to ask the patient to monitor blood glucose more frequently than the usual. For example, he has to check or she has to check blood glucose 2 to 3 hours in every 2 to 3 hours, including during the night. Maybe increased to every 1 to 2 hours if necessary. 1 to 2 hours if necessary. Use of continuous glucose monitoring if available and helpful, as we mentioned in the previous lecture. Management, including the following. How to deal with the patient in sick days management. Monitor ketones frequently. The preferred method is home testing of glucose beta hydroxybiurate, one of the ketones body, is particularly useful for early detection. It is available in kits or strips to check ketone bodies at home. It will give a better monitoring. If available, do this test each time the blood glucose is tested as well. If home testing for the ketones body not available, maybe patient can go for urine dipstick to check for ketones. So especially in type 1, monitoring of ketones is very important. Adjusting the insulin dose. In patients with hyperglycemia and or ketones, what is the usual advice? If blood glucose more than 250 or ketone in blood or urine, give rapid-acting insulin or short-acting insulin. In addition to usual insulin regimen, rapid-acting insulin can be given every 2 hours or 3 hours. Short-acting can be given every 4 hours. Insulin pump patient who are using insulin pump, you can give initial bolus of additional insulin using insulin pen while infusion set is there or assist. It is usually wise to change insulin infusion because maybe there is error or there is, we can say, a block in the insulin pump line. So very important to change the infusion set if the patient on sick days to overcome any technical error available in the pump. When using rapid-acting insulin, you may check blood glucose and ketones after 2 hours, and administration of insulin is recommended at this situation. These insulin have a duration of peak action of approximately 2 hours and effective total duration of action of 3 to 5 hours. Patients with insufficient oral intake, as we mentioned before, may be prone to have hypoglycemia. Insulin requirements are decreased, but not completely eliminated. This is very crucial and very important. Don't eliminate, especially the long-acting insulin during sick days. Why? Because there is insulin deficiency in most of the patients, especially type 1. So to maintain glucose metabolism, insulin should not be stopped even if the patient has not eating, because basal requirement for the usual energy is covered by basal insulin. Management of patients with insufficient oral intake. Maintain oral hydration with fluid that contain both carbohydrates and electrolytes. Intravenous fluid and additional insulin if previous measures were inadequate, for patients who have hypoglycemia and are unable to eat, give ice cold sugar containing liquid. So again, you have to monitor the fluid definitely and to increase the fluid. One of the important tips while you are dealing with a patient in sick days. Again, this slide is very important, especially for the family with type 1 patient. For children, for example, if you have to tell the mother or the father about the following. Indication for seeking urgent medical advice. If your child has any of the following, take him immediately to the nearest primary health care or nearest hospital, any healthcare provider which can assess his situation. What are these points? Age less than 5 years, repeated vomiting more than 2 hours, exhaustion or start to have confusion, hyperventilation or has abdominal pain, random blood sugar persistent hypoglycemia less than 70 not corrected, or continue to rise despite you are giving insulin correction, blood ketone remain elevated more than 1.5 millimole per liter, or urine ketone remain large despite extra insulin and dehydration, comorbid conditions that complicate home care, including, for example, other comorbidities or complications like renal impairment, cardiac, etc. Counseling fact, very crucial, as I told you, in the sick days, improving the conversation, understand the person behind the disease, face-to-face communication, and 5A counseling is crucial in patient with diabetes. You and your patient are experts, so patient-centered care based on the principles of choices, control, and consequences. You cannot make patient do something they are not ready to do. In general, people are interested in their own diabetes. As I told you, patient-centered approach is your way. What about diabetes education counseling session? In any patient with diabetes, it is very crucial to go for education. Unfortunately, as doctors, it is difficult to go for all details from A to Z for diabetic patient. That's why the role of educator is very crucial and important. There are two types of diabetes education visit. The initial one, more comprehensive, and follow-up visit, more focused. There are 4 critical times for diabetes education in general, including other diagnosis, annual assessment to identify the need, when complicating factors available, when transmission of care is there. Diabetes education sessions, as I told you, things to do, multiple visits. Don't do all the things in one visit. Today, you will maybe educate the patient about the hypoglycemia, next visit about hyperglycemia, later on about if he started the insulin, about the injection technique, etc. Listen to patient goal and to patient worries, very important. What are the things to avoid? Don't put all the things in one visit, telling the patient what to do. Listen to him and try, or to her, and try to communicate. Communication is less about speaking than it is about listening and observing. What are the 5 A's of general counseling in any diabetic patient? Advise the patient, personal action plan, assessing the patient, arranging with the patient, assist the patient, and agree about the goals with the patient. So this is if you have a plan to go with a great outcome with 5 A's, you can say that you can go with this 5 A's. Arrange a good relation between you and your patient by phone calls or visiting them, or assessing the behavior, beliefs, knowledge, advise, provide specific information, assess, identify personal barriers, strategies, and agree about the goals as we mentioned. The counseling process: establish rapport and assess, advise and inform, and agree on goals, assist and arrange. So these are the rules of diabetic educator: preparation, assessment, skills, knowledge, and wrap up. As I told you, you have a good relation with your patient, listen to him or to her, and try to be in a good environment and to have a good personal connection with the patient. How to make this counseling setting? You have to be close to the patient, listening to him or and to her. Communication skills should be there, including open-ended questions, listening well, active listening, reflective listening, ask well-planned questions, open-ended questions. For example, avoid questions with yes and no. Maybe you can use questions like, tell me about your impression about insulin. Sometimes close-ended questions are fine, but try to be open mind with open-ended question. Ask for clarification when needed. How do we improve the questions? As I told you before, are you taking your medicine as prescribed? So the better improvement in the question is this way. Many people forget to take their medicine. In the last week, how often did you forget? So this is a more, we can say, polite way to ask, and it will give a chance for the patient to tell you the truth in a good manner or in a more comfortable way. What does listening look like? You see, you have to be active listener for the to them, reflective listening, reaction to the listening, very important. As I told you before, the role of education, very important. Unfortunately, I'm repeating myself. It is difficult in each doctor clinic to go with it. That's why educator or nurses who have education role should be assigned to help the doctor in this can say task. Demonstrate reflective listening. I hate having to check my blood glucose. So what is the response? Sound like checking blood glucose is bothersome for you. Shall we talk about some ways to make it easier? So in this way, there is a good communication between you and the patient. What about empathic listening? If the patient have a reaction, you have to deal with it in a quite good response, help, guide, and discussion. Here, clues about unspoken issues. How do you look when you listen? You have to sit up, look interested, lean forward, act interested, nod your head, avoid starting at computer or not, track the speaker with your eyes. Be aware of body language, as I told you, because the patients are smart and they will listen to you definitely if you give them the proper time and the proper way to listen. But if you are busy with a computer or writing notes, it will be difficult to communicate or give a good outcome. So in assessment, it is better or it is crucial to go for assessment of the patient knowledge, beliefs, behavior, confidence, importance of conviction, skill packet review. You have to again, for example, educate the patient about injection technique. You have to go for all of these steps, including what? Including gathering supply. You will bring glucometer, you will bring strips, you will give, you will bring swab. Understand the medical needs, explain purpose of the visit, get agreement on time, determine the baseline skills, and assess fears or barriers. All these steps very important. Advise and inform, provide information, skills, and knowledge, allow time for patient to practice, focus on survival skills, avoid being directive or judgmental, offer option when possible, which 3 days is best for you to check blood glucose. For example, consider if other instruction topic need to be taught. New information, you can add new information each visit. For example, are they ready for new information? Maybe patient is busy today. Ask the patient to do it next visit. What is the important to the person? Check for the patient understanding of what is being said. Maybe you ask the patient for a wrap up of what did he understand from your session as a wrap up. Again, the skill is very important, will vary based on the skill being taught. You cannot expect the same skills from 18-year-old with diabetes like 70-year-old patient. So different background, different socioeconomics, different we can say basic knowledge, etc., will play roles in these issues. Next issue is begin teach back by asking what was their understanding, as I told you. So after giving session, for example, of hypoglycemia management, ask the patient how you deal with hypoglycemia. If you have, for example, blood glucose of 60 with your child started to lose his conscious level. So in conscious level, if the patient has a conscious level preserved, oral is used. But if the patient consciousness level is lost, definitely glucagon injection should be given, as Dr. Hamid told you yesterday how to deal with these hypoglycemia situation in general or in different scenarios. Again, solving problems, the collaboration way is very important. What does not work, tell patient what to do, provide solution. And the next visit, let the patient write his comment and try to wrap up at the end, and to, as I told you, to give a teach back about how to inject him insulin by using insulin pen, for example. He will show you the first injection in front of you, agree with patient on action, set a follow-up plan, provide handout, document activity in medical record. Clarify understanding, check thought, reteach method is should be encouraged. If diabetes is ignored, what can happen? The good news, problems can be prevented staying healthy. Again, the education process, as I told you, is very recommended, and all people with diabetes should participate in the education. Effective self-management improves clinical outcome, health status, and quality of life are the key outcome for the diabetes management education. This is the care or algorithm of caring. It includes, for example, nutritional for diabetic patient, to go for lifestyle modification, including diet control, education, and emotional health as well. For education, as I told you, at the diagnosis, animal assessment, complicating factor, and at the transitional point from doctor to doctor. This is the general behavioral goal in each diabetic patient. A1C should be less than 7%. So you will give a special goal for the patient in the coming 6 months, for example. Or you will give, for example, a weight loss for diabetic patient with type 2. Usually type 2 are obese or overweight at least. So you ask the patient in the coming 4 months to lose about 20 pounds. This is a smart goal plan. You have to give a specific plan to achieve it in the coming few months, not to have many plans, including A1C, weight reduction, diet control. Try to be in a smart goal manner. So what SMART goal means? S for specific goal, M for measurable goal, A for action-oriented goal, R for realistic and time-bound. So let's give this example, saying I will lose about 15 kilogram I will exercise 4 to, this is the specific. Measurable, I will exercise 4 to 5 times per week. I will follow a special plan. attainable, our action plan. If you have not exercised for a long time, exercise, you will compensate. Instead for using 5 to 10 minutes, you will go for 40 minutes session. Relevant, find a real reason. Example, I want to lose weight because I will get my A1C better control. And time bound, for example, at the end of 4 months, I will try to achieve this goal. I will give you again some of the videos with the summary. I hope it will be interesting for all of you. Try to listen and concentrate, please.
People with diabetes get sick from time to time, just like people without diabetes. The average child catches a cold around 8 times per year. But unlike their peers without diabetes, being sick with a common cold or flu can be more complicated for a child with T1D. Blood glucose might be more unpredictable, and it may be easier to develop ketones when a child with T1D is sick. Remember, ketones are a type of acid, and having too many in the body can lead to ketoacidosis and even death if they are not detected and treated with insulin. Everyone reacts a little differently to being sick, including people with T1D, and a person's sickness can be influenced by many factors, including age, weight, and the type of illness. In general, any questions or concerns about a child's sickness can be handled by their pediatrician or primary care doctor. However, specific questions that are related to T1D and blood glucose should be addressed to their diabetes care team. There are a number of steps that should be taken when a child with T1D is sick. First, it's important to continue delivering insulin doses. During an illness, insulin is still needed for the body to function and prevent ketones, even if the child isn't eating. Even if the blood glucose is low, people with T1D need some amount of background insulin in their system. This is usually maintained with the basal insulin dose or the basal rate for insulin pump users. The basal dose or rate may need to be adjusted by your diabetes care team, depending on the child's specific situation and their blood glucose results. Generally, it will also be necessary to give some bolus insulin every 3 to 4 hours to prevent ketones. Second, it's important to check the child's blood glucose more often than normal while they're sick. The blood glucose may be hard to predict or may change quickly in response to conditions like vomiting or diarrhea. Third, it's necessary to check for ketones even if the blood glucose is in the target range or below. It is possible to have ketones at the same time as low blood glucose. Check for ketones during every bathroom visit using urine ketone strips or test routinely using a blood ketone meter. Be sure to check whether the ketone strips are expired before using them, and do not use any expired strips as they could potentially be inaccurate. You can follow the instructions on the bottle or refer to our video checking for ketones in the blood glucose module for full instructions on how to check for ketones. The sooner ketones are detected and treated, the better. Ketones can lead to further complications that could require a visit to the emergency room. This is why it's important to be extra cautious and monitor the blood glucose even closer when a child with T1D is sick. If you have checked the child's blood or urine for ketones and the ketone result is traced to small, follow these steps. Drink water. Give a correction dose of insulin if the blood glucose is higher than the child's correction target and it has been at least 3 hours since the last correction dose. Keep checking the blood glucose every 2 to 3 hours. Keep checking for ketones at least every 3 hours until the result is negative. If the ketone result is moderate to large, follow these steps. Call your diabetes care team and give them the child's current blood glucose and ketone result. The care team will help determine if you need to give more insulin than normal. Follow your diabetes care team's instructions for giving insulin. Have the child drink water. Check the blood glucose every 1 to 3 hours depending on your diabetes care team's guidance. Keep checking for ketones at least every 3 hours until the result is negative. If ketones are still moderate to large after 2 to 3 hours, call the diabetes care team again. Fourth, drink plenty of water. It's important to stay hydrated during an illness. The extra fluids help to flush out ketones since ketones can only be removed through urine. This chart can help you determine the right amount of water or fluid that should be given every hour. Keep in mind, the fluids do not need to be given all at once. Allow the child to sip or gradually drink the fluids every 10 minutes or when they're able to tolerate the liquid. If the child shows any symptoms of severe hypoglycemia, including confusion, slurred speech, double vision, inability to move or talk, or body jerking, check their blood glucose immediately and give fast-acting carbs or glucagon as needed. Glucagon must be given if the person is unconscious or if a seizure occurs. Glucagon comes in several forms, including injections and nasal sprays, so it's important that all caregivers know what to look for and are trained on the correct medication for the child. If your child begins convulsing or loses consciousness, give glucagon and call 911 immediately. Call your diabetes care team after the child is stabilized or if you need additional help. There are several additional sick day situations where it is advised that you call the diabetes care team immediately. Please call your diabetes care team if any of these situations happen. You need instructions on insulin dosing, the child vomits more than 3 times, there are moderate or large ketones, the child is unable to drink fluids for 3 hours, the blood glucose is over 300 even after giving extra insulin for sick management. There are any signs of ketoacidosis, especially difficulty breathing or deep breathing. You may need to go to an emergency room immediately to treat severe ketoacidosis. If the child is vomiting, it may be best to avoid giving them large amounts of food until their vomiting has stopped. Gradually, you can give them fluids like water or drinks containing electrolytes in small amounts to keep the child hydrated. Keep in mind, drinks containing carbs will still need to be covered by insulin like normal unless you have been directed otherwise by your diabetes care team. Give around a tablespoon of liquid every 10 to 20 minutes. If the blood glucose is less than 100 milligrams DL, you can give some regular soda or other sugary beverage in addition to water. You can gradually increase the amount of fluids when the vomiting stops. Wait a few hours before gradually returning to a normal diet. We recommend starting with something easy to eat, like soup or crackers, as a transition to normal food. If vomiting resumes, allow the child to rest their stomach for around an hour before continuing to give small amounts of fluids. Some cold medications warn that people with diabetes should not use them. These medicines may contain sugars that will raise the blood glucose slightly. It's okay for children with T1D to take these medicines as prescribed. If you have questions about cold medicines and how they might interact with other prescriptions, talk to your child's diabetes care team before giving the medicine. Blood glucose might rise because of the illness or the medication that is given to treat it. Either way, if the blood glucose is high, it can always be corrected later. If a child is taking steroids, notify your diabetes care team if you have any diabetes-related questions. We recommend all of our patient families prepare for sick days before they happen by being aware of what's needed to manage diabetes with an illness. When a child is sick, it can be difficult to bring them along with you when you go out shopping for things that they might need. Likewise, we do not recommend leaving a child with T1D unattended when they are sick. The best practice is to keep a stock of non-perishable groceries that could come in handy during an illness. We call this a sick day kit, and we recommend keeping it in an easily separated container to avoid accidentally using the supplies when they aren't needed. These are examples of some items that you might want to have on hand to prepare for sick days with T1D. Mild carbonated beverages with sugar, including non-diet soda, ginger ale, seltzer, etc. Sports drinks, gelatin, Pedialyte or Infolite, popsicles, regular and diet, soups, saltine crackers, bananas or other fruits, applesauce, bread or toast, graham crackers, ketone strips, blood glucose test strips. You will thank yourself for making the right preparations when you inevitably need them. In our next and final module, we will talk about managing diabetes and special accommodations for kids with T1D at school.
So I hope it was interesting video. I have another one, but maybe it's the time now to have some questions. So please, if you have any query, maybe you can type it down in the chat box. I will try to review the points available in the chat or Q&A. Meanwhile, before I go to the next video. It looks like I have no scientific questions. Okay, so if no questions, maybe I'll give you more time to think about it. For the, if you have any question, we'll go for the next video. Again, it's about our topic about how to deal with sick days management. As I told you before, sick days management is very crucial. How to deal with it, especially in children with type 1. Believe me, it is not easy to deal with type 1 in general, in pregnancy, in children. So it will be more difficult situation if the patient has sickness. It will be difficult to deal with these cases more and more. So understanding the key elements of education in general, including sick days management, rules, as I told you, are very important points to deal with these cases. Okay, I have no here question in the chat box down. So please, if you have any query, you can write it down. I will go now for the next video.
Hello, my name is Maria Chiapetta. I'm a diabetes nurse educator at Ann and Robert H. Lurie Children's Hospital of Chicago. In this video, we'll be learning about how to manage diabetes on a sick day. Children with diabetes get sick just like other children. This may affect their diabetes by causing their blood sugars to be too low or too high. Your child may not want to eat or drink, and they may be less active. All these things make managing diabetes on a sick day challenging. A sick day is when your child has a fever, vomiting, diarrhea, or any other condition affecting their ability to eat or drink. These 4 sick day guidelines will help you manage your child's diabetes on a sick day. Number 1, drink plenty of fluids. Number 2, never skip your insulin. Number 3, check blood sugar frequently. And number 4, check urine for ketones. Let's talk about each of these guidelines in greater detail. Number 1, drink plenty of fluids. Your child can get dehydrated quickly on a sick day due to sweating from fever, vomiting, diarrhea, or high blood sugar. Some signs of dehydration are dry lips or mouth, eyes that look sunken, irritability or sleepiness, concentrated or dark urine. If your child is refusing to drink, encourage them to take small sips from a spoon every few minutes. Here are some other ways to sneak in fluids. Try foods that melt. For example, popsicles, ice cream, sherbet, jello, ice cubes. Or try foods that are high in water. For example, applesauce, oranges, watermelon, soup, or pudding. Most children should drink at least half a cup of fluid an hour, but older children may need more. Contact your child's diabetes team for specific recommendations. What you give your child to drink will depend on their blood sugar level. If the blood sugar is dipping towards the lower end of their target range, they should be given liquids that contain carbohydrates. If the blood sugar is within or above the target range, they should be given fluids without carbohydrates. If your child is able to keep down liquids without vomiting, they should be slowly offered small amounts of food. Choose foods that are easy on the stomach, such as crackers, toast, sherbet, jello, rice, and popsicles. The second sick day guideline is never skip your long or intermediate acting insulin. This is the most important sick day rule. Your child always needs to take their usual long or intermediate acting insulins like Lantus, Levemir, NPH, 75-25 mix, or basal insulin from their pump. This basal insulin is needed to give their brain, heart, lungs, and muscles energy and should never be missed. If your child is not eating, they may need less fast-acting insulin like Humalog, Novolog, or Apidra. However, they must always take their long or intermediate-acting insulin. If you have any questions about possible changes in your child's insulin dose on a sick day, contact your diabetes team. The third sick day guideline is check your child's blood sugar frequently. On a sick day, test blood sugar every 2 to 3 hours. Blood sugars may be lower than usual due to a decrease in appetite. Blood sugars may also be higher than usual and require additional insulin correction doses. Frequently testing the blood sugar will help you make the needed adjustments. The last sick day guideline is check for ketones. On a sick day, test for ketones every 4 hours or every time your child urinates. Check for ketones even if your child's blood sugar levels are in range or low. It is common to see trace or small amounts of ketones on a sick day. Encourage your child to drink fluids and water. Moderate to large ketones require immediate action. Contact your child's diabetes team immediately for further fluid and insulin advice. Moderate or large ketones can lead to diabetic ketoacidosis, or DKA. DKA is a serious condition that needs immediate medical attention. Signs of DKA include excessive thirst, abdominal pain, nausea, vomiting, weakness or extreme fatigue, shortness of breath, fruity smell to breath, confusion. Contact your child's diabetes team immediately with any of these symptoms. Let's review the 4 sick day guidelines. Number 1, drink plenty of fluids. Number 2, never skip your insulin. Number 3, check blood sugar frequently. And number 4, check urine for ketones. I hope you find these sick day guidelines helpful. Sick days can be very challenging. If you have any trouble managing your child's diabetes on a sick day, please contact the diabetes team.
Okay. I hope it was again a good review for all of us. How to deal with the sick days management in diabetic patient. So just a quick reminder, if you are interested in diabetes and endocrine, please follow our Twitter account, EndoDMOS. It's about new update and a quick review about endocrinology and diabetes, EndoDMOS, ENDODMOS. I think before going for break, it's the time now to receive your questions or your comments. I will give you a chance. Please, if you have any query, write it down in the chat box. I will try to review the chat box and the Q&A box as well. If you have any query or any questions, we can discuss about today, topics and yesterday as well. Okay. It looks that no here any questions, so I will maybe give some comments about today lectures in general before going for break. In the beginning, today we talked about insulin regimen, including basal bolus regimen, and we tried to know the different types of insulin available in the markets, how to manage diabetic patients, how to give proper management, sometimes pre-mixed insulin, sometimes basal bolus regimen, according to the clinical situation available. And as we mentioned before, pre-mixed insulin can be given sometimes if the patient they are not familiar. It is difficult to use many times per day injection. Maybe it's your choice to go for pre-mixed insulin as well. We tried our best to showed the difference in the management between basal bolus and pre-mixed insulin. I showed you that the pre-mixed insulin difficult to control because it has two components, and in this situation it is difficult to control both of them. I mean the long-acting insulin or intermediate-acting insulin and rapid-acting insulin. That's why it is preferred to go for the more flexible regimen like basal bolus. So it is the most flexible and best one to be used is the basal bolus or multiple daily injection regimen. After that, after we talked about the rapid-acting insulin and different types of insulin, we tried to focus on some of the updated drugs available and technologies. I showed you the CGM. I showed you some of the drugs available and the new approved medication in pediatric age group. Hope that in the coming few years, inshallah, we can see the more promising drugs and more promising technologies to be seen in the clinical practice. Really, it is helpful. As in my practice, the introduction of the GLP-1 agonist 4 or 5 years back was really, we can change a game changer or a technical, a very trickable point. Before GLP-1 agonist, the only solution was to increase the insulin doses. But after the introduction of the GLP-1 agonist, it was very helpful to reduce the weight of the patient because it decreases the appetite as yesterday. I mean, as yesterday, as yesterday, Dr. Hamid told you about the usual GLP-1 agonist, so it decreases the weight because it has a satiety effect, anti-satiety effect. That's why we have a better the reduction in the weight, and definitely the more insulin sensitivity decrease insulin resistance. I think this is the what we did today, and in the coming few slides after break, inshallah, we'll try to see how to go for food care in diabetic patient. Again, one of the recommendation to go for annual screening for food care and retinal screening in the diabetic patient. So it is very crucial to how to have some hints how to go for this assessment. And inshallah, tomorrow we'll try to complete the journey to deal with other situations like older population. We'll give some practical cases in diabetes as well. I will give topic, inshallah, about insulin pump therapy, which is the most, we can say, highly technology one. I hope that it was okay. And we'll go for a break right now, and inshallah we'll meet at 9 p.m. So please go for the break till 9 p.m. You can enjoy coffee break, and due to different time zones in the kingdom of the Isha prayer, you can go for prayer meanwhile, and inshallah at 9 p.m. sharp we'll go for the last topic. Assalamu alaikum wa rahmatullah. Welcome everybody again to the last session of today presentations or today activity. My last topic today is to deal with diabetic food. One of the major assessment panel or assessment tool is to go for diabetic food assessment in diabetic patients. Here is the talk of how to deal with this assessment. First, we'll go for some epidemiology. Cost of diabetic foot disease in developed countries, 20% of total healthcare resources for diabetic food care. In developing countries, 40% of total healthcare resources consumed. So actually, it is a high cost. Physical examination is the most important issue while we talk about the assessment of the diabetic foot. Neurological assessment including sensory neuropathy, motor neuropathy, autonomic neuropathy, and vascular assessment including the pulse, dermatological assessment, texture, turgor, and temperature. Also, musculoskeletal foot structure, deformity, mobility, ulceration, location, and depth of and appearance. So this is one of the method in which you are using the myofilament to detect any neuropathy in the patient with diabetic foot or diabetic patient. The vascular, as I mentioned, you have to pulse, detect the pulse. You will see if it is palpable or not palpable. You may use non-invasive studies. You may go. Looks like the slides are lost. So I'll try to share again. I hope now it is clear. I mean the slides. So I hope that the slides are okay. If you have any problem, just type it down in the chat box so we go for the technical support. Let's go further now about how to deal with diabetic or diabetes foot in diabetic patients. These are the diseases that you may see. You see here the discoloration in the left foot of this patient. Again, fungal infection may be one of the diseases that is observed. Amputation sometimes is the approach for management in such a case. Some neuroischemia may be presented like this way with discoloration, and you have in this situation go for ulceration, and the ulcer evaluation need to be seen by vascular surgeon or general surgery, of course, including observation of the location for the forefoot, midfoot, and the depth of the ulcer. Is it superficial or is it deep? The classification by the surgeon, drainage, is there is any pus, for example, etc. Maybe if it is infected, you have to go for culture, for microbiology, looking for the odor, color, drainage. And as I mentioned before, maybe culture should be taken to choose the best antibiotic. And the X-ray, including bone scan, CT scan, MRI, also of the options available to see if the bone, for example, affected, reaching to osteomyelitis. Here, the ulceration, how to detect the ulceration and to see if it is getting bigger. And again, you have to standardize the treatment for diabetic foot ulceration, appropriate treatment modality, including debridement and treatment with the infection or antibiotic, definitely saline dressing, offloading to decrease pressure on extremity, arterial revascularization if indicated. All these are the usual maneuvers while we are dealing with diabetic foot. Here, one of the examples of the ulceration in the heel, and definitely you have to go for, as we mentioned, offloading, to decrease pressure using maybe some shoes to decrease the pressure in some points. And also here is the dressing, how you are dealing with dressing in foot ulceration cases. Sometimes contact cast may be used. DM routine follow-up in general in any diabetic patient, identifying the alphabet of key numbers and exam to monitor diabetes, including frequency and target goal. What are his usual routine? You have to look for the goals, including hemoglobin A1C, blood pressure as well, cholesterol. You have to go for dental examination, eye examination, foot examination, kidney function test, smoking cessation you should be advised, discuss patient rule and diabetes education rule, review skills for accurate checking and recording of key metrics. All these are very important issues while we are dealing with such case. What are the types of things that are monitored in any diabetic patient? It is classified actually into two entities or into two categories. What are these two categories? The first entity is it is by the physician, including the weight of the patient, hemoglobin A1C, blood pressure, cholesterol and lipid profile, kidney function test, foot, eye, including dilated examination, nerve function, dental, mental health, depression, smoking status. Why all of these? Because as we mentioned, complications of diabetes is or may affect any organ in the body. That's why it is important and critical to deal with all these complications as a prevention from the beginning, as a screening. For example, type 2 diabetes, maybe the retinopathy presented from the beginning, from the first year. That's why it is recommended to go for dilated retinal examination in the first year of the diabetic type 2 patients. But the opposite is there in type 1 patient. Type 1 patient, it is recommended to go for retinal examination, not from the first year, 3 to 5 years later is the recommendation for the retinal examination. Why? Because type 1, if it is there, it will dramatically will appear with emergency. It will not wait years. But type 2, maybe he has many years asymptomatic, and after a while, he will have these symptoms. During few years, complication may occur. And also one more point, during pre-diabetes, there is a cardiovascular risk complication may be observed sometimes in such a patient. Let's go now for the second entity or the second category, which are the things observed by the patient, including the weight again, the blood pressure, if the patient has a machine at home and the patient has glucometer or CGM, continuous glucose monitoring. He will check blood glucose at home, as we mentioned before, to see if he is or she is at the goal, fasting blood glucose 80 to 30 in usual population. or most of the patients, and less than 180 postprandial 2 hours. But GTM cases or pregnancy cases, children, old, elderly have different goals. Healthy behavior, including eating and calories, carbohydrate, sleep pattern, etc., should be covered by the patient as well. To make it simple, maybe some reminders or mnemonic to remember what are the parameters to be checked, including A, B, C, D, E, F, K, S. So this is the mnemonic: A for hemoglobin, A1C, B for blood pressure, C for cholesterol, D for dental, E for eye, F for food, K for kidney function, S for smoking. So to remember the mnemonics A, B, C, D, E, F, how to screen for the complication, which are the parameters should be followed in the diabetic patient with this mnemonic. Our topic here, as I told you, is the food examination. So chronic hyperglycemia can affect both nerves, blood vessels, and also circulation, and increase infection risk, as I showed you in the previous images from the atlas. Amputation prevalence is high, unfortunately, in diabetic food. About 1 million diabetes-related amputation occur every year. Daily food exams at home can prevent up to 50% of these amputations. Complete food examination every year by a doctor to check for neuropathy is very crucial. If you have a nurse who is taking care of food care, again, very important to follow up cases. If you have any query about vasculopathy, refer your patient to a surgeon for further assessment. A1C, again, the target goal, as we mentioned, in majority of patients less than 7%, 7 to 8% in higher risk individuals. It should be done 2 to 4 times per year according to the situation. If the patient not controlled, every 3 months. If the patient is controlled, maybe you can extend it to 4 to 6 months according to the clinical and overall situation. Blood pressure. Usually the blood pressure target less than 140/90, and it should be checked every visit. LDL cholesterol should be less than 100, and in high critical cases or high risk patient, it should be less than 70 target, especially in cardiac patients. And dental examination checked 2 times per year, but also advised. The eye examination, as I told you before, to make sure that no eye disease, and go for annual checkup, foot examination daily at home by the patient, and at least annually by the doctor to make sure no cuts, no sores or redness in the foods. The kidney function at least twice per year. The smoking, to make sure no smoking or smoking cessation advised every visit if the patient is still a smoker, and give your advice every time. Body mass index, we know that the diabetic type 2, unfortunately, increasing nowadays due to the sedentary lifestyle and increased weight in the community, even in the pediatric age group or in the adolescent, using electronic devices for games, no activity, encourage sedentary lifestyle will push us to such diseases prevalence increase, unfortunately. Body mass index, as we know, the normal is between 18.5 up to 24.9. Underweight or BMI less than normal if it is less than 18.5. Overweight between 25 up to 29.9. but obesity more than 30 BMI. So in overweight and obesity category, type 2 diabetes mellitus is increasing, especially if the patient has family history of type 2 diabetes. How to calculate it? You calculate it, divide your weight in kilogram by your height in meter. Then divide the answer by your height again to get your BMI. This is an example. 60 kilogram is the weight. Divide by the square of the height in meter, 1.65 multiplied on itself. So if you go for this division, you go for the BMI. I think I will give you a revision now about food examination in this video. Please, if you have any query or any question for discussion, maybe you can type it down in the chat box so we can discuss it after seeing this video for a quick revision for what we mentioned about the food examination, which is one of the critical point in any patient with diabetes.
Hello, my name is Dr. Sadaf, and today we will be performing diabetic foot examination on Dr. Kamran. First, I'll obviously greet the patient and ask for the consent, and then I'd ask for the adequate exposure for the examination. Hello, Dr. Kamran.
Hello.
How are you doing?
I'm good, thank you.
I'll be performing the diabetic foot examination on your lower limbs today. For that, thank you for being adequately exposed, and I'll be performing certain procedures on your limbs. Would that be okay with you?
Yep.
Okay, thank you very much. So starting with the examination, we will first go for the inspection. As the patient is adequately exposed, we specifically need to look at the limbs below the knees. So on inspection, we will look for we will look at both limbs bilaterally, and we will look for any discharge, any redness, any swelling, any sinuses, scar marks, specifically because diabetic patients have impaired sensations in their extremities, so they could have wounds or injuries which they're not aware of. So any scar marks. Also, we would look for any obvious pigmentations, any loss of hair or any abnormal hair distribution because of the compromised vascular supply, and also something to be noteworthy is any ulcers, and there are specific areas for ulcers. So we will look at both the limbs, but specifically at the feet, at the pressure areas where there could be sores or ulcers. So that's the bunion area, and specifically the heels. So Dr. Kamran, if I could please lift your foot, look at the heel area on the right foot, and look at the heel area on the left foot now for any ulcers, and also for the bunion area on the left side as well. Another area to look at for any fungal infection or ulcers is the interdigital webs. So open all the web spaces and look for any interdigital ulcers or fungal infections. After looking at ulcers and the pigmentations, hair distributions, and also look for some skin shininess, that is also because of the vascular compromise. So this is our inspection. We've looked bilaterally. One last area to be looked at after you've seen the dorsal aspect is the back of the limbs. If I could please raise and look for any ulcers or any scar marks, and all the things that we discussed from the front, you need to look at from the back as well. And after that, moving on to the gait. So I would ask the patient to stand up from the couch and walk a few steps, and high steppage gait is normally something to be aware of in diabetic motor neuropathy. After the inspection, I would move on to palpation. So I'll be gently touching your both limbs, and if it causes any pain, please do let me know. So for the palpation, you will first of all look at the temperature. For temperature, you need to compare both the limbs and use one of your hands so that your temperature is the same for the patient. So comparing bilaterally, starting from downwards going upwards. So from the foot first, because normally due to vascular compromise, diabetic patients have cold extremities. So you could either go in a zigzag manner or in an ascending manner. comparing the same areas. And it's good from the back of the hand. And lastly, for temperature, you also need to look at the calf temperature. So over here, shouldn't be warm because it would indicate some infection or something just going on. After the temperature, we would go for the tenderness. I would be gently pressing on your limbs. If that causes any pain or discomfort, please do let me know, okay? So starting from the feet and looking at the patient's face. Specifically the feet, and then the calves are something that you need to look for, tenderness. And the calves again. After the temperature and tenderness, we will look at two things which are related to the vascular supply of the foot, which is the capillary refill. So we will press on the nail for about 5 seconds and then remove and see if the nail reperfuses in less than 2 seconds, which is normal. If there's a delayed refill, that means there's a vascular compromise. And we will do the same on the other limb. So the capillary refill is normal on both sides. The last thing to see for vascular compromise is the pulses. So there are two pulses that we specifically see, the dorsalis pedis and the posterior tibial. The dorsalis pedis is the artery running between the first and the second flexor tendons of the foot. So palpate for it here and bilaterally. So the pulses are palpable and bounding normally in both feet. The other pulse is the dorsalis pedis, which runs behind and can be felt behind the medial malleolus. So bilaterally palpating those as well. So the pulses are palpable and normal. So there is no vascular compromise in this patient. So this finishes our general examination. Moving on to the neurological examination in a diabetic foot. I'd be touching different objects on your limbs. The first of which will be a cotton wisp. So we are, first of all, we're going to test the touch sensation, and this will be fine touch sensation for the patient. For this, we will be using a cotton wisp on the limbs, and for the soles, because it has hard skin, we usually use a monofilament. So make the patient aware of what it feels like. So this is a wisp of cotton, and this is what it looks like, and this is what it feels like, okay? I'll be touching this on various places on your lower limbs, and when you feel it, please say a yes for me. During this procedure, I'd like you to close your eyes and say a yes for me whenever you feel it, okay? So we will be touching this bilaterally and comparing the sensations and going in a zigzag manner. So, and test all the dermatomes of the lower limbs. So please say a yes when you feel the wisp of cotton. Usually diabetic patients have a glove and stocking pattern, loss of sensations in the lower limbs, so they might not feel.
Yes. 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 Yes.
Thank you very
Yes.
much. So normally, as long as you don't get a sensation or a yes from the patient, you keep on going up to check the level of neuropathy. So my patient has peripheral neuropathy till mid-calf, and he can feel the sensations from above it. So you discard this in a clinical waste bin. And the second sensation that we will be testing the patient on, and I did say that on the sole of the feet you need to check the fine sensation as well of touch, but that would be with a monofilament. Now we will check the sensation of proprioception in the patient, for which I will explain to the patient what I'll be doing first. So Dr. Kamran, I'll be moving your thumb and then your ankle up and down. So the thumb I will move like this. This will be up and this will be down. Okay, I would like you to close your eyes and let me know if you feel it up or down. Okay, similarly I might do it on your ankle as well. So for the ankle, this would be up and this would be down. Okay, and let me know if how you feel it up and down. Okay, if you could please close your eyes now. Now
This is down,
okay, and what do you feel now?
up,
Okay, and now?
down,
Okay, and you need to check bilaterally, so where do you feel your thumb now?
down,
Okay, and now?
up,
And now?
down,
Okay, and where do you feel your foot now?
up,
Okay, and now?
down,
And now?
up, down.
So the proprioception was impaired in the toes, but it is normal in the ankles. Moving on from proprioception, we will be checking the vibration sensation in the patient. So for the vibration sensation, we use the tuning fork with the longer limbs, and it is the 1281 frequency that we use. So we will, Dr. Kamran, so this is a tuning fork, and this is what it looks like, and this is what it feels like. Okay, I'll be touching this on various places on your lower limbs, and you need to tell me if you feel it vibrating. Okay, thank you very much. Okay, do you feel anything?
Yes,
Okay,
yes, yes, yes,
thank you very much. So the four places that we check on the lower limbs are the medial side of the big toe, the medial malleoli, the shins, and the patellar bone. So my patient had no sensations up till the shin, and from above he could feel the vibration sensations, and they were intact. Moving on, we need to check the pain sensation. So this is a neuropin. This is the blunt side of it, and if you remove the cap, there'll be a sharp pin inside. So this is a neuropin, and I'll be touching with the blunt side first on various places on your limbs, and this is for coarse touch. So wherever you feel, say yes for me. Okay, and after that I'll be checking for pain sensation. Okay, and I will let you know before I start, but if you feel a pain prick from a pin, you will let me know with a yes. Okay, thank you very much. So starting with the core sensation, say yes for me with your eyes closed if you feel anything. So doing it bilaterally.
yes,
Okay,
yes, 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 yes.
okay, thank you very much. So coarse touch was positive above the mid chin. So now checking for pain sensation. This is a neuropin. You remove the cap. This is only to be used on one patient only. So you remove the cap. Now I will be testing the pain sensation, Dr. Kamran, and with this sharp pin. So please let me know when you feel the pain. Okay. Touch it gently, not pricking the patient too much, and looking for the patient's expressions on the face.
Yes, Yes.
I'm sorry.
Yes. Yes. Yes.
Okay, so the pain sensation is intact above mid-calf and it is altered below the calf. This, remember, needs to be thrown in the Sharps bin and is to be only used in one patient at one time. Okay, the last thing that is to be done is the reflexes. So we normally check the ankle and the knee jerk in the patients. For that, you need to position the patient in a way. So if I could please flex your knee, and so you need to extend or plantar flex the ankle. Feel the Achilles tendon. So the ankle reflex is intact in the patient, so you check bilaterally. And after that, if the ankle reflex is not intact, you ask the patient to, if you could please slide your legs down by the end of the couch for the knee jerk. You ask the patient to cross the limbs over one above the other like that, so that the patient is relaxed. You feel for the quadriceps tendon. And you see a knee jerk reflex. So you do, thank you, if you could cross your left leg up bilaterally. So you see the knee reflexes are intact in the patient. Thank you very much. This concludes our examination for diabetic foot. I hope you enjoyed and benefited. Thank you.
Okay, thanks for your listening. I am done with this topic. So if you have any question, please write it down in the chat box. So meanwhile, I will remind you about topics reviewed here in the course. Yesterday, we tried to focus on epidemiology of diabetes, classification and diagnosis, different types of diabetes as well. We gave a quick overview for non-insulin drug therapy and insulin therapy, and also diabetes during pregnancy management. One more issue about the complication, including microvascular and macrovascular complication, and hypoglycemia and awareness. For today, we try to go deep for the types of insulin, including basal insulin, rapid acting, and pre-mixed insulin. And we try to go for the insulin indications, barriers, etc. And we also went for the diabetes emergency, including the two famous categories, diabetic ketoacidosis and hyperosmolar non-ketotic status, including diagnosis and management. Also, we focused on how to deal with sick days management in diabetic patients, especially in the children, and diabetic food assessment was the last lecture. And also we saw the lecture of the update. We know the field of diabetes is changeable, quickly changeable. That's why we tried our best we tried our best to cover the update in diabetes, and we hope to see these medications which is under development soon in our market. Tomorrow, inshallah, we'll go for the education about insulin injection in some details, and to know how to initiate and titrate insulin in type 1 diabetes mellitus and in type 2 diabetes mellitus as well. We'll talk about the special conditions of diabetic, including patient during fasting Ramadan, during exercise, older population, and pumps and we'll go for some practical cases at the end. This is our Twitter account, IndoDM, or if you are interested, follow us in this Twitter account. It's a pure scientific account about update in diabetes and endocrinology field. Thanks for the audience for the listening. Thanks the logistic support from Dorota Riyadh. I hope it was really interesting, and inshallah will continue to be interesting in the last day tomorrow. نراكم غدا على خير بإذن الله. تصبحوا على خير والسلام عليكم ورحمة الله تعالى وبركاته.